Good evening or good morning, depending on where you are. I'm Dr. Idman Sarah, General Secretary of Young Ophthalmologists of Morocco. On behalf of the U Morocco board, I would like and love to welcome and thank everyone taking the time being with us today for this event, highly anticipated, first of its kind, Retina Summer Camp. We have an outstanding lineup of speakers today, national and international, talking various subjects on vitreoretinal surgery. Dr. Mortada Hassan from Egypt with his talk, Pills for Managing Advanced PVR. Dr. Shamil Louaya from Morocco, talking about retinectomies, when, why, and how. Dr. Carlos Mateo from Spain, treating the management of macular folds after retinal detachment surgery. Dr. Bennani Mohammed from Morocco with his topic, Vitreoschisis and Diabetic Vitrectomy. Dr. Jorge Calzada from USA, tech trends in vitreoretinal surgery, ultrasonic vitrectomy and exoscope with augmented reality. Dr. Ahmed Sallam from both Egypt and USA, talking about vitrectomy in endophthalmitis. But first of all, we will start with our rising star in retina, the young ophthalmologist, Dr. Yassine Malek. I'm very happy and pleased to co-moderate this webinar with him. Dr. Yassine Malek is senior resident in Wad Dahab Military Hospital in Agadir, and he is the chair of Vitreoretinal Scientific Committee of YUM. He has made tremendous efforts to make this event today happen. So thank you so much, Yassine, for your efforts. And we will be starting the show. He will be starting the show to talking about vitrectomy step-by-step for beginners. Dr. Yassine Malek, the show and the floor is for you.
Thank you, Sarah. Thank you. So hello, everyone, and welcome to the Young Ophthalmologists of Morocco Retina Summer Camp. I am Malek Yassine, and I am thrilled and honored to present you this webinar today alongside Dr. Sarah, General Secretary of YUM. So first of all, we would like to thank all the speakers who are top leaders in their respective field around the world and among the best vitreoretinal surgeons who kindly accepted our invitation to be part of this webinar and enlighten us with their personal experience in managing challenging and difficult vitreoretinal cases and discuss such controversial topics. I would like to thank also the audience who gathered today during summer vacations to combine the useful with the pleasant. It is also a huge honor for me to speak today among my master and among this prestigious panel. So, I will not pretend to cover during my presentation all aspects of vitrectomy, but I will try to describe its major steps as an introduction for the youngest among us for the next more sophisticated presentation. So I will share my screen with you. Can you see it?
Perfect.
Okay. So pars plana vitrectomy is a procedure which name derives from vitreous and ectomy. That means removal of vitreous. Instruments access the posterior segment through cannulas introduced into the pars plana to treat many conditions such as retinal detachment, vitreous hemorrhage, epiretinal membrane, endophthalmitis, and many more. So pars plana vitrectomy basic setups include the vitrectomy machine, which can have a peristaltic pump like the Dork EVA that controls flow rate and can be safer for beginners as aspiration is independent of the resistance of the environment and flow rate remains stable. However, venturi pumps, such as the Stellaris from Bausch & Lomb, controls vacuum and is less predictable when switching environment from BSS to vitreous. So in these pumps, modulation of vacuum is key to avoid any retinal injuries. What about cut rate? The higher the cut rate, the better and the safer the vitrectomy. And nowadays we have cut rate up to 15,000 cuts per minute or even 20,000. Duty cycle is also an important parameter as it is the percentage of time the cutter port is open. So the higher the duty cycle, the safer for the retina as latest machines have a duty cycle of 100% in dual blade cutters. Basic setup includes also the viewing system, with a microscope that should have a good magnification, excellent stereoscopic vision, automatic inverter, and a slit lamp. Conventional contact lens requires a trained assistant. The use of viscoelastic, sutured lens are quite dependent of corneal transparency, but however, they have a wider angle than non-contact viewing systems such as the ReSight seen on the video from Zeiss, which does not require an assistant, is quite independent of corneal transparency and pupil dilation. However, it has a less stereoscopic image. So basic setup includes 3 ports. The first port for the infusion that maintains the intraocular pressure set by the machine. The second port for the light pipe that permits the safe endo-illumination of the retina. And finally, a third port for instruments such as vitrector, forceps, and many others. A fourth port is possible when using a chandelier light to free the non-dominant hand for bimanual surgery or silicone oil injection. So step 1 is anesthesia. Our preferred technique is the subtenon block, as it is a safer technique than the peribulbar or retrobulbar block. It consists of opening the conjunctiva with a venous scissor in the inferotemporal quadrant. Then we use a custom bent needle, 20 gauge bent needle at the extremity with a smooth end to inject 4 cc of 2% lidocaine into the subtenon space, achieving it without chemosis, as you can see. So it permits a good anesthesia up to 1 hour, however, bad akinesia. General anesthesia is preferred in trauma cases, pediatric population, and one should always have in mind that nitrous oxide is prohibited with gas tamponade. Step 2 is trocar insertion. As valve trocar are inserted transconjunctivally 3.5 millimeters behind the limbus in pseudophakic patients and 4 millimeters in phakic patients. Distance is measured with the back end of the trocar. So standard location of the infusion is around 4 or 8 o'clock, depending on the eye, and the infusion should never be in front of a retinal tear to avoid increasing the retinal detachment. The 2 superior trocars are introduced near the 3 and 9 o'clock meridians, avoiding the horizontal meridian to avoid any long ciliary nerve injury. Patch of trocar insertion is a controversy, as 25 and 27 gauge are generally introduced in an oblique fashion and uniplanar. However, in 23 gauge, we prefer a biplanar insertion for its self-sealing properties. Angle of insertion should be around 20 and 30 degrees. So classical technique is using a Bottic forceps to displace the conjunctiva from the entry side. Then we insert the trocar in a 30 degrees angle into a biplanar fashion, aiming toward the optic nerve. Then we should always check the infusion. It is mandatory, and we use the classical mirror technique with an instrument reflecting the end of the trocar to be sure it is in the vitreous and not suprachoroidal. Then we insert the 2 superior trocars into the same biplanar fashion. Displacement on the conjunctiva is possible without using the Bottic forceps and only with the trocar, and introduction of both superior trocars can be simultaneously and can help stabilize the globe. Classical sequence taught to beginners is beginning with anterior vitrectomy, then core vitrectomy, then PVD induction, and finally peripheral vitrectomy. However, this sequence is not always true and depends on the case. So anterior vitreous is classically removed first without the use of the ReSight. It is more difficult in phakic patients such as this one, and it is done with a circular fashion. And the cutter should always stay at the periphery of the lens and be directed downward, not like on this video, as it is directed upward and can injure easily the posterior capsule. One should always avoid the midline of the lens, avoid any lens touch, and swipe the cutter to the non-dominant hand to remove any contralateral anterior vitreous, as we can see here. Careful dissection of residual anterior vitreous adhesions is mandatory to prevent any posterior capsule touch, as we can see here. Then, core vitrectomy. And in contrast to cataract surgery, you will be surprised by how much space you have in the vitreous cavity and how you hold the instruments almost perpendicular toward the optic nerve. So vitrectomy is easy in vitreous hemorrhage because vitreous is stained with blood. Settings are on highest vacuum, highest cut rate, keeping the cutter stable in the center and using the wide field length, such as the yellow lens from the resite. Visualization of clear vitreous is always harder without chromovitrectomy, and one should always hold the light pipe close to the vitreous cutter to make the vitreous appear. PVD induction. For beginners, it is recommended to stain posterior yellowoid with triamcinolone. Inject diluted triamcinolone in front of the optic disc with infusion off. Then switch on the infusion and aspirate the particles. Posterior yellowoid can be easily recognized. Then, so the vitreous cutter is positioned at the nasal rim of the optic disc. Cutter is switched off and suction is increased at the maximum, drawing the vitreous cutter toward the lens, permitting a safe PVD. One should always have in mind to never cross the equator to avoid any iatrogenic retinal tears. For the peripheral vitrectomy, one should always set the cut rate to the highest and lower the vacuum or the flow rates depending on the machine you use to prevent any iatrogenic break. So cutter opening, as we can see on the video, is always perpendicular to the peripheral retina, so do not engage it. In bullous retinal detachment, as we have seen, we always use the PFCL to stabilize the peripheral retina and make it more easy to shave. Sorry. In rhegmatogenous retinal detachment, there are some special considerations in vitrectomy, which are in fractional or mixed diabetic retinal detachment. One should always do a 360 degrees vitreorexis to release vitreous anterior-posterior traction. Then, in rhegmatogenous retinal detachment, extensive release of the vitreous around the tear is needed to prevent any vitreous contraction postoperatively, which can be a cause of surgery failure. And finally, one should always check for iatrogenic breaks at the end of the procedure with the self-indentation and holding the light pipe with the other hand to check for any retinal tear, because when it is undiagnosed, it can induce postoperative retinal detachment, especially in macular surgery and macular hole surgery, and it can worsen the prognosis of the patient. Chromovitrectomy, or how to make the invisible visible. So there are many dyes in surgery, among them triamcinolone acetonide, which is a steroid, and which crystals can deposit on many acellular tissue, such as the vitreous, the ILM, and the periretinal membranes. There is also trypan blue dye, which can stain both periretinal membranes and vitreous, but it cannot stain the ILM. And there are too many forms. Here in Morocco, we have only the iso-osmolar one, and it stains better when we do a fluid air exchange. Finally, the baby G, or brilliant blue G, stains the best ILM and is used when we intend to peel the ILM in macular hole surgery. There are so many membranes to peel. So material needed includes a plano-concave lens or a non-contact 60 diopter lens from the resite, and it depends on the surgeon. Forceps like the ILM, the Tano forceps, or the asymmetrical forceps, or even Tano diamond scraper or Phoenix flex loop from Alcon. So, for ILM peeling, there are many techniques and multiple techniques, and among them the blunt opening of the ILM with the so-called pinch and peel technique. It is my preferred technique, as we hold the forceps and press a little bit over the retina, grabbing only the ILM without touching the optic fibers. Then, as we can see here on the video, then we create an opening into the ILM, and the free edge of the ILM is grabbed and peeled easily in multiple times with a mix of some centripetal and centrifugal forces. During fluid air exchange, the BSS inside the vitreous cavity is exchanged against air. So the air may be used as itself as a tamponade or exchanged against a longer lasting gas or even silicone oil. So the technique consists of introducing a flute needle, holding the backflash into the vitreous cavity, then switching the infusion from BSS to air. So air enters from the highest point behind the lens, and as we can see here, the bubbles gathering behind the lens, and BSS is removed with the flute needle into the lowest point in front of the optic disc, while air comes from anterior to posterior retina. When PFCL is used in retinal detachment, it is filled until the posterior edge of the retinal break, as we can see here. Then a fluid exchange is performed while draining from the break with the fluid needle. Once the break is dry and the peripheral retina is dry, we can completely remove the residual PFCL. So laser retinal photocoagulation is indicated in many pathologies such as vascular pathology, diabetes, retinal vein occlusion, coats, in retinopexy during RD repair, and even in preventive cerclage. So I generally prefer the curved laser probe because it can always be perpendicular to the retina depending on its rotation by the surgeon. Laser can be done under air or BSS, and energy is titrated depending on the whitening of the retina. One should always avoid lacerating or injuring retina when going from posterior to anterior retina because of the concavity of the globe. A minimum of 3 confluent rows around the chair are necessary to induce a good retinopexy. General principles of trocar removal are starting always with superior trocar, stopping the infusion before removing any trocar, then removing it without or with the light pipe. It depends on the surgeons. Then we should always massage the sclerotomy and check for any leak. So in fluid-filled eye, indirect signs of leaking are chemosis and Descemet fault. However, in air-filled eye, bubbles are sign of leaking. So when sutures are indicated when there is a sclerotomy leaking or there are systematic in silicone oil-filled eyes. So sclerotomies are generally sutured carefully with a partial thickness 8.0 vicryl with transconjunctival sutures parallel to the limbus in a 2-on-1 fashion. Finally, visualization is key of success. So follow these tips you should. Mydriasis you will achieve before the surgery. Cornea you will protect with the viscoelastic. Epithelium you will scrap. The lens you will not touch, or the perioperative cataract you will deal with. Finally, the fogging of the eye well during fluid air exchange you will combat by even using a backfish needle or viscoelastic. Thank you for your attention, and you are all welcome to visit us in Agadir, Morocco.
Thank you very much, Yassine, for your beautiful presentation, amazing iconography, very good dexterity, and a beautiful surgical hand, really. Thank you. And also very didactic, because as we said before, it's very complicated to summarize all the steps of vitrectomy in such a small time. So well done, good. And we will open the discussion now. If you have any questions, comments, or something to add for Dr. Malek. From the panelists, maybe? No? Okay, maybe I will have one question for you, Malek, if you don't remind.
Yes.
Oui, Dr. Bennani, no? Okay. So my question is, how do you check the infusion if you have like a poor visibility, maybe in vitreous hemorrhage or endophthalmitis or something like that?
Yes, that's a good question. There are many alternative techniques to check the infusion, not the one I showed, as one can push the cannula until we see it under the eye well or under the lens. However, we should really depress hard the eye, and we use it frequently when there is a choroidal detachment associated with retinal detachment. In some cases where media opacities are really does not allow the visualization, one can use the infusion into the anterior chamber. That's what we do in endophthalmitis cases, but I think that it will be more explained by Dr. Ahmed Sallam in his presentation. Also, you can use the light pipe and see if the light pipe is suprachoroidal or in the vitreous cavity. It can help a lot.
Okay, thank you.
Are there any comments from the panel about that? Yes.
Yassine, congratulations. Very, very nice presentation. Let me tell you, you explained, this is very, very, very basic, but you explain how you enter 3 millimeters in pseudophakic eyes and 4 millimeters in phakic eyes. But in high myopes, and many people, Hassan, I think, is going to say the same. You know, in high myopes, even you can enter a 5.5 millimeters to trying to reach the macular area when they have this posterior staphyloma, because the normal forceps is difficult to arrive to the macular area. Then in high myopes, if you are driven, you know, with macular traction maculopathy or a retinal detachment macular hole, even you can go a little bit further, you know, to 4 millimeters, but it's the exception.
Okay, thank you for the tip.
May I add something? Concerning the insertion of the infusion cannula. I think a very important point to be considered is the pressure of the eye. If the eye is hypotenuse, then you have to reform the globe, because hypotony means that either the ciliary body is detached or the pars plana is detached. So before going into the eye, in hypotenuse eye, you have to reform the globe. And as you have said clearly, you have to indent the infusion cannula and make sure that the metal of the cannula is seen shining inside the vitreous cavity and not covered by the pars plana epithelium or any other tissue. So if it is covered, then you should stop infusion. You go from the other side, the other cannula or the other sclerotomy with a needle or with a cutter, and then you remove the tissue over the infusion cannula. This is very important. Otherwise, you are going to be, I would say, punished by suprachoroidal infusion. The other point is you spoke about 3-pore vitrectomy, and I think we have to speak about 4-pore vitrectomy, because the chandelier light really offers many advantages during the vitrectomy, especially in complicated cases. It is an additional light. You can indent for yourself. You can stabilize the peripheral part of the retina. So you don't need an assistant. You have access to all parts of the retinal periphery. So I think insertion of the chandelier light is important, is critical in these cases. So we have to speak about 4-pore and not 3-pore vitrectomy, except in simple cases. The third point is during shaving of the vitreous base, you should stabilize the posterior retina with PFCL, and you should direct the stream parallel to the surface of the PFCL bubble so as not to disturb the bubble. And then you should not direct the aspiration pore toward the retina. So you cut by the side of the aspiration pore. Try to let the vitreous come to you and not you go to the vitreous. And this is assisted by indentation from outside, may help to stabilize the peripheral retina and minimize the instance of iatrogenic breaks. No one is immune from creating iatrogenic breaks during shaving of the vitreous base, but I think these measures may decrease this risk. Also using the minimum vacuum, the highest cutting rate. Some prefer to use the peristaltic pump at this stage, but for myself, I use the Venturi pump for all the procedures. Otherwise, you have a very elegant presentation that elaborated all the steps of the surgery. Thank you, Yassine.
Thank you, Professor. May I ask you which gauge chandelier do you use, the 29 or the 27?
I use the 25 chandelier light made by Alcon, but there are other
like the watch chandeliers,
very useful. No, it's one. It is inserted in one place. Usually I put it in the empty quadrant, which is the lower nasal quadrant or closer to the 6 o'clock meridian. Sometimes I put it opposite the meridian, which needs more work during the operation, or the main work during the operation. So the location of the chandelier light is also, where to put it is also, I think, is important.
Thank you for this great discussion.
Yes, we have maybe some questions from the audience.
Yes.
First one, it's how do you avoid the contact lens when you do vitrectomy around the trocars? And the second one, it's what do you think about slit lamp on the microscope surgery?
As I earlier said in the presentation, to avoid contact lens in phakic patients, you should never cross the midline. If you do not cross the midline, you will not touch it. So when you're doing your peripheral vitrectomy in the homolateral vitreous to the dominant hand, you can use the wide field lens and do your peripheral vitrectomy. However, when you do it on the contralateral retina, peripheral retina, so do not cross it. So you can depress, lower the infusion to the lowest, like 20 or even 15 IUP, and depress until you have the retina that comes to the middle of the vitreous cavity, or use your backhand and do it with the non-dominant hand. That's how you do not touch the lens.
All right.
Is all the panel agrees with that, or maybe there are some comments?
More point is that you have to make deep indentation. So you don't, as you said, you should not cross behind the lens, but this is not always possible. So if you are going to operate on the opposite direction, just perform deep indentation toward the center of the vitreous cavity, go with the probe, so both the probe and the indented part are located away from the lens. So deep indentation may also avoid touching the back of the lens. And you have to be very careful in young patients, because in young patients, the lens is soft, and if you indent, the lens will be compressed and will bulge posteriorly. So the possibility of injury of the back surface of the lens is higher in young patients with soft lens, with softer lenses.
Yes, thank you. So thank you for this great discussion. Let's welcome our next speaker, Dr. Hassan Mortada, who will be speaking on purpose of managing advanced PVR. So Dr. Hassan Mortada is an emeritus professor of ophthalmology and vitreoretinal surgery senior consultant at Cairo University, Egypt. He is a former president of the Egyptian Vitreoretinal Society and a member of many international societies such as European Vitreoretinal Society, Veil Retina Meeting, Retina, and many others. He has been invited guest speaker in more than 30 Vitreoretinal Societies meeting all around the world. So, Dr. Mortada, thank you for accepting our invitation.
Thank you, Yassine, for the opportunity. I'm really happy to be with you. I have shared my screen. I don't know whether it is visible now or not.
Yes, I can see it.
Okay. My talk is about management of advanced cases of PVR. And before going into the discussion of management of PVR, I would like to just to give a small mentioning of how to optimize visualization. And since 2 years now, I'm using the wide-angle digitally assisted visualization system. It is really very advantageous in management of these complicated cases because of many advantages that can be discussed in another symposium. From the clinical point of view, PVR has mainly two components: posterior PVR, which is located posterior to the insertion of the vitreous base, and it is more common in primary PVR and less common in recurrent PVR. And the second component is anterior PVR, which is located anterior to the posterior insertion of the vitreous base. And it is more common in the recurrent PVR. There are too many classifications for PVR, which are hard to remember, but I think this is the one that is important from the clinical point of view. Before going into the vitreous cavity, you have to manage the anterior segment, because this is your window to visualization of the posterior part of the globe. So if you are confronted with a narrow pupil, you have to dilate the pupil. If not responding to mydriatic stent, you have to dilate it mechanically, but try to avoid injury, surgical injury to the iris. In some cases, like in trauma cases, maybe the cornea is totally opaque. So either use endoscopy, which I'm not trained to use, or you fit the eye with a temporary keratoprothesis. So you remove the part of the opaque cornea. And this is a case of trauma that was fitted with a Bennani lens, total detachment. And the lens was removed. The eye was fitted with a temporary keratoprothesis. Under the temporary keratoprothesis, the visibility is truly excellent. And again, you have to make sure that the infusion cannula is free inside the vitreous cavity. I will start by what we used to do usually. We start by dealing with the posterior PVR, and our targets is to excite the vitreal gel, the pigment clumps, the transvitreal traction bands, peeling of adherent posterior haloid if it is existing, peeling of all epiretinal membranes, extended eye lamp peeling, and then you stabilize the posterior retina with PFCL. The first case is a simple case of epimacular proliferation, and you can see that the probe is used to peel the posterior haloid. And the epimacular proliferation is on the back of the attached posterior haloid, and you can see the glistening or the sheen of the attached posterior haloid. So the probe is used to detach the posterior haloid and with the epimacular membrane, but after that, you have to stain the underlying retina to remove the eye lamp. This is again a case of more extensive epimacular membrane. Again, it is removed with the forceps, and then you inject triamcinolone, because in some cases there are shreds of the vitreous that are still adherent to the underlying retina. So and these should be removed, and then you stain the internal limiting membrane, and you can see that this only part of the eye lamp that was removed with the epimacular membrane, but the rest of the internal limiting membrane is still there, and this part has to be removed, otherwise you are going to suffer from development of post-operative macular pucker. This is how to deal with extensive multiple star-shaped folds. And this is a recurrent case following previous vitrectomy done elsewhere. And then I'm using the eye lamp in order to remove the epimacular membranes. The peeling, according to the classic teaching, is from posterior to anterior. So because the posterior retina is thicker than the anterior, and here you catch the edge of the epimacular membrane. And the peeling here is not classically from posterior to anterior, but you have to move or decrease the adhesion of the epimacular membrane to the underlying retina. You can make side-to-side movement or even from anterior to posterior, but you have to take care not to create iatrogenic retinal breaks. This is to show that the use of the color filter, this is the green filter on the digitally assisted visualization system. It reduces the glare, it increases the contrast, and with the use of this system, you can improve the depth of visualization. You can increase the magnification without compromising the resolution. And practically, you can perform all the techniques with the use of the digitally assisted visualization system. A very important and critical step is to do an extended peeling of the internal limiting membrane. You can do it without PFCL, or you can do it under PFCL. Here I'm using this is the eye-lamp forceps, and using the pinch technique, as you've seen explained, in order to peel the internal limiting membrane over the largest area possible. And if we look into this case, usually I injected in a fluid-filled eye, you can see that here the macular area is folded with no apparent or visible epimacular membrane. But once you remove the internal limiting membrane, you will have flattening or relaxation of this fold in the macular area. The eye lamp, as I said, is peeled as to the periphery as possible, and what I call the extended eye lamp peeling, because here you are removing the scaffold for the future proliferation. Sometimes you are confronted of a case of posterior PVR and a macular hole. And in this case, you have two goals: to peel the internal limiting membrane over an extensive or extended area, and at the same time use the eye lamp flaps, what I call the multi-layer flap, or what I call the envelope technique, in order to assist the closure of the macular hole. So under you cannot do this except under PFCL. So under PFCL, the internal limiting membrane is peeled, stopping short of the edge of the macular hole, and bring the flaps over the macular hole in order to assist in closure of the macular hole. So you are relieving the tangential traction, and at the same time provides, here I'm peeling the internal limiting membrane over areas of epimacular proliferation or epimacular membrane. So you are removing the internal limiting membrane with the overlying epimacular membrane. This is the case of a closed funnel. It looks like a closed funnel, but if you examine carefully, there are no epiretinal membranes. So you should think immediately of something underneath the retina. I'm using the serrated forceps to peel the attached posterior hyaloid in order to remove the posterior hyaloid, which is another scaffold for cellular proliferation. And then it is excised. I injected brilliant blue. Sometimes I inject brilliant blue, sometimes trimethylene alone, and opening the funnel with PFCL. Under PFCL, you start to peel the internal limiting membrane, but you will see that this is not the internal limiting membrane. It is another layer of the posterior hyaloid, which should also be peeled to the posterior border of the vitreous vase, and you continue the peeling, and now you can see there are areas of anterior PVR. This is different from the previous case. It's a closed funnel case, but you can see that the retina is fixed with epiretinal proliferation. So the epiretinal proliferation are clearly visible. There are a lot of pigmentation. You peel the posterior hyaloid or the epiretinal membrane to the posteriorly. You open the funnel with PFCL, and you can see the flow of the Schlerian phenomenon, or the flow of the fluid. And after injecting brilliant blue to look for the internal limiting membrane and other epiretinal membranes, you can now peel the internal limiting membrane, which is visible. And in these cases, the eye lamp is usually shreddy. It is not you cannot peel it in one piece, but you have to spend some time, and you may restain until you peel the internal limiting membrane over the largest area possible. Another case of a closed funnel. Here I injected directly beryllium blue. I used the forceps to get an edge of the plug closing the funnel, which is peeled from posterior to anterior. And you can perform this technique with the bimanual approach. You can use two forceps, you can use a forceps and scissors. But here I could peel it only with one hand. Another injection of beryllium blue, the internal limiting membrane is extensively peeled, working from the center to the periphery, and trying to remove the scaffold for future proliferation to improve the long-term stability in these cases. Then we move to anterior PVR. You should not move to anterior PVR except when you accomplish the mobilization of the posterior retina and you stabilize the posterior retina with PFCL. What our goals is excision of the contracted basal vitreous gel, peeling of epiretinal membrane, whether unimanual or bimanual. You may have to perform retinotomy, removal of subretinal proliferation, complete retinal reattachment with PFCL, and then you perform the endophotocoagulation. This is a case of anterior loop traction. You can see that the retina is dragged. The posterior retina here, this part of the retina is dragged to the retinal periphery by this anterior loop traction. Under scleral indentation, the chandelier light has tried to peel the peripheral epiretinal membranes, sometimes working with the forceps, sometimes with the small gauge vitrectomy probe, but I'm trying to save as much of the posterior retina as possible. But at the end, you will not be able to free the peripheral part of the retina totally, and ultimately you will need to perform a retinotomy. I know that Carlos would like to put a buckle in these cases, and this is another option. Shaving of the basal vitreous gel is really very important, and the use of the green light on the digitally assisted visualization system is very helpful. There are multiple retinal breaks on the temporal side, and the retina here is functionless. This patient has manifestations of a Stickler syndrome, and I'm doing vitrectomy to get rid of the ischemic retina, and after finishing this is a direct PFCL silicon exchange. This patient has a recurrent detachment, and if you look to the periphery, most of the peripheral vitreous was not removed, and the primary surgery told me that he shaved the vitreous base under air, which in my opinion I do not recommend, because you are compressing the peripheral vitreous against the retina, and the end result is such proliferation. And then, to complete the surgery in this eye, there was anteroposterior traction. So retinotomy was performed, shaving the anterior flap, or cutting the anterior flap to guard against postoperative hypotony. This is the case of severe anterior PVR, again using the green light, which decreases the glare. I'm using the serrated forceps to peel as much membrane from the retinal periphery as possible, working from posterior to anterior, sideways, and then at the end, the functionless peripheral retina has to be removed in order to achieve long-term attachment of the posterior retina, and performing retinotomy, endolaser, and then direct PFCL silicon exchange. This case has a recurrent retinal detachment following scleral buckle and vitrectomy. And you can see that the retina here is shortened. So you have to perform retinotomy. And in doing retinotomy, you have to connect the circumferential part with the retinal periphery in order to release both the circumferential traction and the anteroposterior traction. Vitrectomy is, retinotomy is done using the small gauge vitrectomy probe. This is a 23 gauge, and then working to remove the anterior flap. And retinotomy should be performed posterior to any line of traction, posterior to any retinal breaks. You may have to supplement the circumferential retinotomy with a sort of radial retinotomy in order to also to read the circumferential traction. The last topic is subretinal proliferation, and we have a variety of subretinal proliferation. This is the case of a severe PVR after stabilizing the posterior retina, working bimanually, and the best way is to use two forceps. The subretinal space is entered, catching the subretinal sheet or strands with one forceps, and then this is helped by the forceps, the other forceps, and I prefer also the serrated forceps for this task. Again, anterior PVR, you shave the posterior haloid. There are multiple retinal, peripheral retinal breaks. There are extensive subretinal proliferation. You go to the subretinal space using two forceps. Again, working bimanually, and the subretinal extensive proliferation is completely removed, and you complete it for 360 degrees retinotomy, PFCL, endolaser, and then PFCL silicon exchange. This is the last case. It's an extensive, it's an extreme case of PVR. This is the last eye of this patient. He underwent several vitreoretinal procedures, including scleral buckling, gas, vitrectomy with gas, vitrectomy with silicon oil removal, injection of re-injection. And you can see that the retina is fixed, and there is a strong, large cord of subretinal proliferation that it looks like a cloth string that was removed through an extensive temporal retinotomy. There are extensive anterior proliferation and risk subretinal silicon oil. The risk of hypotony in these cases, post-operative hypotony, I mean, is high, but there is no other option except to operate. Subretinal proliferation were meticulously and completely dissected. So the retina is completely mobilized, cleaned the anterior surface, the posterior surface. And then I discovered that there was an incarceration, the retinal incarceration. I don't know what is the reason. It was not a trauma case. PFCL was injected, and you can see the retina is somehow rotated. So you have to correct the position of the retina, endolaser, and then silicon oil, PFCL silicon oil exchange. So by showing these videos, I hope I could explain the main techniques used in the treatment of advanced PVR. And thank you for your attention and for the opportunity.
Thank you, Dr. Mortada, for this great talk and amazing videos, helpful tips and tricks, and also a helpful strategy to deal with advanced PVR. So I will ask the panelists if they have any comments or questions about this presentation.
Gentlemen, I just joined late, and I need to say, Dr. Mortada, Dr. Hassan, that what I got to see was quite impressive surgical skills, and I gotta congratulate you on that. And I also need to say hello to my friend Carlos Mateo, from the place where my parents are from Spain. So, hola Carlos, ¿cómo estamos? Anyway, just wanted to say hi.
Welcome, Dr. Jorge. Thank you for being with us today. So I have some questions for Dr. Mortada about dealing with such complicated anterior PVR with transparent lens. So do you ablate it to do?
I didn't hear you. What was the question?
Yes, when you have a transparent lens in such complicated advanced PVR and anterior loops, and you can't go that anterior, so do you ablate the lens? In this case,
ablate,
yeah,
you mean
lensectomy.
remove the
Do you
lens?
do a lensectomy? Yeah, do you do a lensectomy or a phaco
Yes,
before?
all these cases, if the patient is pseudophakic, well and good. If the patient is aphakic, also well and good. But if the patient is phakic, usually I do combined phacoemulsification, implantation of a 3-piece foldable IOL, and then proceed with the vitrectomy. So all these patients were either pseudophakic or aphakic. You cannot do this technique in a phakic eye.
Yeah, of course. And what are your indications for a first intention encircling band with the vitrectomy?
I don't put an encircling band with a vitrectomy. I only do encircling band when I'm doing a buckling procedure. But when it is a vitrectomy, I do not put a buckle, and I depend on relieving the traction from inside. So I'm using this technique since a long time, and I think I never regret not putting a patient a buckle.
What about the panelists? Do they agree or they have other preferences?
Talking about PVR, I know Hassan for many years, and we always discuss these topics. You can do different things to manage this kind of PVRs. For example, I start from the anterior PVR instead of posterior PVR. I always peel under before carbon liquid. I always put buckles, except in 1 or 2% of the cases with PVR, because at the end, when you cut the retina goes to a little bit posterior. A little bit posterior means larger circumference. Then, a buckle helps you to reattach the anterior retina. Then, I'm convinced that, I'm convinced that Hassan is convinced that you don't need it, but I'm convinced I need it. And, there are so many ways to deal with these kind of patients. But when I see you, because you are so experienced, Hassan, you are so experienced, but, to peel membranes without perforated carbon liquid in these so mobile retinas, carry the risk to grasp all the retina, not the epiretinal membrane or the internal limiting membrane. Then, I think it shortens a lot, the surgery if you use it. We mentioned this in 89 in New York, and we never stopped to do this. And I always use it. And, the risk to have a bubble of perforated carbon liquid under the retina peeling the posterior PVI is so rare. You mentioned, Yassine, and you, Hassan, mentioned that be careful with the jet stream of the infusion if you perform a retinectomy, because, this is the source of these subretinal membranes. But, every surgeon, experienced surgeon, have different ways to manage all of these things. But, Hassan, I stay the same. I'm putting buckles in my PVR cases. You cannot remove all the traction because, at the end is not only the peripheral vitreous that you never remove it totally, is also the retina that is shortened, because there is an intraretinal PVR mentioned here, a professor in Spain and other surgeons, because the retina contracts and the circumference is larger. But this discussion is never ending. We can spend here 3 months discussing this, but great talk, great surgeries.
Well, dear Carlos, here I have to take the opposite view.
Sure.
Because, for example, I rarely use PFO for my peels, and one of the concerns I have is subretinal PFO. You know, and I've seen enough patients with subretinal PFO, and when you don't have enough traction, it goes underneath, and now you're dealing with subretinal PFO, and that's a headache I don't want to have. So I'll use PFO, but very few cases. And the other thing that I would also perhaps intentionally want to create some drama in discussion here, Carlos, is that I rarely do a buckle. You know, multiple reasons. First, because I rarely do a primary buckle. I think buckles, in my opinion, are the best case operation for a young patient with an attached hyaloid, but I rarely do a buckle on a patient with pseudophakic extended retinal detachment. And when I have PVR, I do not disagree any at all. Yes, it's true. You have intraretinal proliferation, you have intraretinal contraction, and I agree with you. No matter how much peripheral vitrectomy you do, you cannot remove all the hyaloid. Now, this is where I change, because I don't think that you remove the hyaloid, and because I don't think the buckles have any biological change on the intraretinal component. I believe that retinectomy is the best way. And when you put a buckle and you do a retinectomy, you're basically increasing the likelihood that it's going to fall this way. So that's, I don't want a buckle in a retinectomy. I will admit that probably my cases require more chronic silicone oil than many other patients that have buckles. But I also think that the worst thing of having a poor visual potential eye is a poor visual potential eye that looks bad and hurts. And a lot of people with buckles, I mean, your buckle, Carlos, you may have put many more buckles than me. But I see a lot of patients with buckles and in people that go in and try to move the buckle back again, and then the patient has ptosis and the eye is looking red and is chronically uncomfortable with surface disorders, and the vision is equally as bad, you know. And then we end up fighting, oh, your retina is more attached than my retina. And I'll say, well, you know what, maybe my patient has a little subretinal fluid at 6 o'clock, and maybe the patient needs silicone oil chronic, but the eye looks perfect and the visual outcome is almost the same. So I'm happy with that, and I can be a lot faster in my procedures, and my standard PVR cases rarely take more than 25 minutes. But claro, we can argue this back and forth, como dices tú.
How many times we will have to discuss these topics? You know, we don't have time. You know, I strongly advise to do it under peripheral carbon liquid. You know, so rare that peeling posterior PVR is you have a subretinal bubble of peripheral carbon liquid. You have this peripheral, you cut the retina, and when you cut the retina and you don't put buckles, then you have to cut the retina more posterior because you leave an anterior part. You never can relax the anterior part. But you know, again, these discussions is never ending.
I will add one little point, which I've been doing lately quite a bit, which is instead of doing a standard retinectomy on PVR reoperations, is to do a 2-port vitrectomy surgery through the oil and lift the hyaloid, the peripheral hyaloid, with the forceps, in actually creating an intentional retinotomy, not a retinectomy, that relieves at the point that the traction is gone. And then you do retinectomizes the peripheral retina. But we, as you say, I agree, we can keep on fighting this forever. So wonderful. And by the way, Dr. Hassan, it's great meeting you, and impressive.
I have few comments, but I'm not going to discuss whether the buckle is important or not, because we spent our lives discussing this issue with Carlos, which to me is not only a friend, is more than a brother, because we spent our lives doing this type of surgery, and we are trying to offer the best to our patients. So it is mere difference in the points of view, but the target is to benefit the patients. First, peeling under PFCL may give you the impression, false impression, that you have released the traction. But peeling without PFCL, you are working on a retina that you are witnessing and observing its mobility. So the more you remove the membrane, the more the retina is mobile. And not just the effect of PFCL, because PFCL gives you the impression that this retina is now flat. So I think working under water, under BSS, in my opinion, gives a real impression or real clue to the state of the retina. It is true that you cannot remove the posterior hyaloid. That's why I recommended extended eye lamp peeling, because once you remove a large area, an extended area of the internal limiting membrane, then maybe you have removed much of the attachment of the vitreous fibrils into the retina. So you are not left with vitreous. And the proof to this is that you never have proliferation in an area where the eye lamp was removed or was peeled. So why not to extend the peeling to the periphery in order to try to eliminate the risk for reproliferation? The third observation is to treat recurrence by modifying the buccal, which I hate. You are dealing with an internal problem with an external technique. Add to this the distortion of the globe, the astigmatism induced by the buccal. So the problem is inside the eye. Go inside the eye and solve the problem. And the problem will not be solved by putting additional buccal or modifying the buccal. So you are overestimating the value of the buccal in solving the problem.
And damaging the macular surface.
And exactly. Add to this the bleeding from reopening these recurrent cases. The sclera may be damaged already. And the last thing is I do not like to operate under silicone oil, because here you have limited, suppose bleeding occurs during surgery under silicone oil, then how are you going to deal with it? So why not to go remove the silicone oil, do the operation as perfect and as precise from your point of view, and then refill the eye with silicone oil. But operating under silicone oil may be feasible in simple problems, but in major problems, you cannot, for example, you cannot perform a retinotomy by just pulling the membrane under silicone oil. I think this is unpredictable. It may induce complications. So in my humble opinion, you remove silicone oil, redo the vitrectomy, inject PFCL, inject silicone oil as if you are going to operate from the very beginning. This is my opinion.
Only one comment, and stop here because it's so long. You say, and before carbon liquid, you feel that the retina is fastly more attached. I don't think that you are more able to see membranes with the retina detached and moving like this. I try to remove all the membranes. I stain the membranes. I go there for many times. I remove the interlimiting membrane as far as possible. You know that mid periphery, it begins to be very difficult because it breaks and it breaks and it breaks and it breaks. Then, before carbon liquid, and again, Jorge, it's wonderful to peel the posterior PBR. It stabilizes the retina. You see perfect. There are no folds. You can re-stain. Yes. But I think for me is I can't see your point of view. But anyway, great discussion.
Okay, I agree with you. But usually I don't start by injecting PFCL from the very beginning. But in many situations I peel under PFCL because as you said, the retina is mobile, and also the peeling of the internal limiting membrane is much easier under PFCL. But not in all cases. Not in all cases you are obliged to use this. May be the point of difference. But anyhow, it is expensive. A very small part of our.
This is the only problem. Look at Jorge.
And
Hassan, look at
there
Jorge.
are much more important
in the United
things
States. When you operate in a surgery center, not in a hospital, it's very difficult to justify the economics of the cost of the peripheral carbon.
Here is one main issue. For us, it's not a main issue. For U.S. surgeons like you,
Absolutely.
It's very
I have
expensive.
to choose when I use the peripheral carbon.
You have to
But my
think
default
twice.
is not to use it.
Absolutely. I agree. I fully agree. We are in a different situation. Yeah.
Thank you so much. Thank you so much for this beautiful
Yes.
discussion. I think we will have to make
Sorry,
a
Sarah,
new.
there is a last comment, Dr. Bennani.
Sorry. Sorry.
Yes.
Okay.
Just a few words about this question of buckle. I joined Dr. Mateo's team. I'm a fan of combined surgery, vitrectomy with buckle in the severe cases. And except on the cases when we perform very large and posterior retinectomy and when we put silicone oil. And second thing, when we remove silicone, we are very, very happy to have the buckle after silicone because I think we have less complication after silicone removing. I'm sure we have no definitive response, I think, for this question, but it depends on the experience, on the habits of surgeon. But I am a user of combined surgery vitrectomy with the buckling.
Great.
Okay, we made two teams. Right. Thank you so much for this beautiful discussion. And now we'll have another topic where we are forced sometimes to sacrifice a part of the retina to save the rest. And we are talking about retinectomy. But the questions are why, when, and how. And to answer them, we couldn't find better than our eminent expert in the field, Dr. Shamil Louaya. Dr. Shamil is the head of ophthalmology department in Wad Dahab Military Hospital and professor of ophthalmology at University Ibn Saud Agadir. And thank you so much for accepting the invitation. Dr. Shamil, it's for you.
Thank you, Dr. Sarah. I take this opportunity, first of all, to thank Young Ophthalmologists of Morocco for associating me with this great and famous panel. Otherwise, knowing well that more than half of participants are French-speaking, Young have opted that I will present in French. And after this very nice presentation made by Dr. Mortada, who detailed the PVR in a beautiful style, I will continue in the same channel. And without too much delay, I will attack this very interesting chapter concerning retinectomies and retinectomies. Les parties abordées lors de cette présentation comprennent les indications. Donc, on va répondre à la question when et why et les techniques de rétinotomie et rétinectomie. Nous savons que le but de la chirurgie des décollements de rétine, c'est de recoller la rétine à sa position initiale et en présence d'une PVR sévère. La prise en charge du décollement de rétine, il exige des procédures plus complexes pour soulager ou relâcher les tractions présentes. Ce sont des manœuvres bimanuelles avec pelage des membranes, de la membrane limitante, libération du nœud de PVR. Et dans certaines situations, la traction rétinienne, elle persiste et ne cède pas. Donc, il est raisonnable d'envisager d'effectuer une rétinectomie pour supprimer cette traction. Premièrement, le terme rétinotomie, il désigne la coupe de la rétine. Et il peut varier d'un petit trou créé pour drainage du liquide surrétinien ou le retrait d'une membrane surrétinienne à une coupe qui s'étale sur 360 degrés pour libérer une traction périphérique massive. Tandis que la rétinectomie, elle signifie l'excision de la rétine, on va enlever la rétine, et elle peut intéresser seulement une petite partie. Tel est le cas lors d'un lambeau, d'une déchirure à fer à cheval par exemple, avec lambeau, ou bien une très grande surface, à savoir une excision totale d'une rétine fibrotique périphérique. Un peu d'histoire, donc c'est en 1979 que Macular était le premier à décrire le concept de rétinotomie et à être le pionnier de cette méthode pour gérer le traitement des incarcérations rétiniennes dues à des plaies sclérales traumatiques. Et en 1987, Zevonovich a été le premier à souligner l'utilité de la rétinectomie dans la gestion de l'APVR et les tractions rétiniennes avancées dans les décollements de rétine complexes. Par la suite, de nombreux chirurgiens et chercheurs ont commencé à finaliser les indications, les résultats pour traiter les décollements de rétine sévères. Maintenant, on va voir les indications de la rétinectomie. Il faut noter que, grosso modo, on a recours à la rétinectomie, soit pour accéder à l'espace sous-rétinien, et là, on va voir ultérieurement, tout de suite, pourquoi, soit pour relâcher une rétine devenue cartonnée et non étirable, non élongable. La première indication, c'est pour accéder à l'espace sous-rétinien, pour, par exemple, drainage, ce qu'on appelle drainage rétinotomie. Donc, là, on va créer un trou rétinien qui permettra l'élimination du liquide sous-rétinien. Donc, il est préférable que ce trou de rétinotomie soit fait en périphérie. Parfois, les indications intéressent un corps étranger qui est situé en sous-rétinien. Imaginons qu'un cas de décollement de rétine, le corps étranger qui a glissé en arrière de la rétine, alors là, on est obligé de faire une rétinotomie si la déhiscence n'est pas visible pour accéder à ce corps étranger et l'extraire. On va voir comment faire par la suite. Parfois, on a recours à la rétinotomie pour enlever des gouttelettes de perfluorocarbone passées sur rétinien, surtout si elles sont dans la région foveolaire. Vous savez bien qu'elles sont toxiques pour la rétine. Parfois, pour faire un prélèvement tissulaire lors d'une rétinite, une uvite ou bien dans la pathologie néoplasique. Une autre indication, c'est lors de la translocation maculaire, donc pour faire ces manœuvres de rotation et de passage de la rétine. La deuxième grande indication de la rétinectomie, c'est ce qu'on appelle la rétinotomie de relaxante et qui va viser à relâcher une rétine qui est devenue non réapplicable par les procédures chirurgicales habituelles. Parfois, dans certains PVR avancés ou bien une rétine fibrosée, où l'élasticité, l'étirabilité, l'élongabilité de la rétine ne sont plus possibles malgré les forces intérieures appliquées, que ce soit par l'air, l'utilisation du perfluorocarbone, bien sûr, après pelage, bien sûr, de toutes les membranes existantes, ou bien malgré les forces extérieures, à savoir une indentation. Donc, on est obligé de faire une rétinectomie de relaxation. Et comme il y a une relation, une loi de Hooke sur l'élasticité, donc qui simule toutes les structures élastiques, qu'il y a une corrélation linéaire entre les forces et l'élongabilité. Donc, l'augmentation de la résistance et de l'extensibilité de la rétine implique des forces importantes pour étendre la rétine. Et bien sûr, ces forces, à un certain moment, seront plafonnées et limitées. Et la seule option, en ce moment-là, c'est de couper la rétine pour la plaquer sur la paroi. D'autres vecteurs de force y interfèrent. Il faut rappeler qu'il y a un équilibre entre plusieurs forces au niveau de la rétine, les forces d'adhésion, les forces radiales et les forces tangentielles. Et vous voyez donc l'état normal en premier. La deuxième, lorsqu'il y a un décollement de rétine, il y a un redéploiement des vecteurs de force. Et lorsqu'on va sectionner, faire une rétinotomie sur la rétine, il y a une suppression de certaines forces, ce qui va faciliter de réappliquer la rétine et de recréer un nouveau point d'équilibre des forces rétiniennes. Mais par un message important, presque la majorité des décollements de rétine avec PVR, comme a montré le Dr Mortada, sont traités sans rétinotomie relaxante, par vitrectomie et indentation chez certains autres. Les rétinectomies relaxantes ne doivent être pratiquées que si les autres méthodes ont échoué et n'ont aucune chance de succès. Et il y a des facteurs qui vont influencer la décision, la localisation de la prolifération, l'étendue de la traction, la difficulté de l'utilisation de l'indentation sclérale. Tous ces facteurs vont en pré- et péropératoire nous indiquer cette rétinotomie de relaxante. Je répète que l'indication de la rétinotomie relaxante, chaque fois que malgré l'ablation de toutes les membranes et les nœuds de PVR, la rétine reste contractée et raccourcie. Et il y a plusieurs situations, comme vous voyez, donc, qui conduisent à cela, passant de la contraction focale jusqu'à la prolifération périrétinienne fibrotique extensive. On va voir une vidéo sur ça dans la section comment on fait. Donc, la première indication pour la rétinectomie relaxante, c'était lors de l'incarcération rétinienne post-traumatique faite par Macular. Vous voyez là, c'est un cas simple d'incarcération via un point perforant, mais il peut donc bien sûr s'agir d'un cas plus difficile avec incarcération presque de la rétine et l'aspect classique de l'entonnoir. Donc, d'autres indications en cas de prolifération vasculaire avec fibrose rétinienne extensive pour enlever le mur interne dans le Retinoschisis congénitale que l'on va voir avec le Dr Bennani ultérieurement. Une indication aussi anecdotique de la rétinectomie relaxante, c'est pour le traitement des glaucomes réfractaires au traitement habituel. On va puiser d'une complication habituelle de la rétinectomie qui est l'hypotonie post-opératoire pour traiter, donc, dans certains cas, et d'ailleurs, M. Joussen et son équipe ont rapporté sur une étude de 44 IE traités par rétinectomie qu'il y a une amélioration significative chez 52,3 au long terme sur une étude qui s'est étalée sur 5 ans. Maintenant, dans ce chapitre, on va voir les techniques chirurgicales pour réaliser ces rétinotomies et rétinectomies. Tout d'abord, donc, la première indication pour faire le drainage rétinotomie. Donc, pour faire ce trou, on va donc soit directement par l'endodiathermie d'une façon continue sur une zone, donc soit marquer une partie circulaire, ou bien avec l'endodiathermie d'une façon continue, on va créer notre trou. Parfois, on peut user, on entoure par le diathermie, on continue le travail par la succion et du vitréotome et la coupe du vitréotome. Et si c'est le cas de rétinotomie relaxante lors d'une incarcération post-traumatique de la rétine, c'est la même chose, on va faire une endodiathermie autour de l'incarcération, une rétinotomie sur 360 qui va s'étendre par la suite, comme vous voyez là, après échange air-fluide. Ça, c'est le cas simple de l'incarcération rétinienne. La rétinotomie relaxante peut être faite soit d'une façon circonférentielle totale ou partielle, ou parfois radielle, ou l'association des deux. Donc, on rappelle, il faut toujours se rappeler du principe général, si jamais de rétinotomie de relaxation avant l'ablation de toute membrane discellable. Donc, user donc le perfluorocarbone postérieur pour voir et savoir que la circonférentielle, elle est préférable chez beaucoup de chirurgiens par rapport à la radiale. Pour faire une bonne chirurgie, donc il faut une bonne visibilité qui est garant du succès de l'opération. Du coup, il faut bien ajuster son microscope ou son système 3D et veiller à bien préparer le patient et le segment antérieur pour assurer une bonne visualisation des manœuvres en segment antérieur. Donc, enlever toute cataracte gênante. Travailler chez un sujet pseudophaque, c'est plus facile. Et la préférence donc d'utiliser le chandelier et couplé avec l'endoillumination, c'est important, mais pour faire les manœuvres d'appointe, donc c'est l'endoillumination directionnelle qui est plus supérieure que le chandelier. Il faut faire un équilibre entre les deux. Donc, dans le cas pour faire la rétinotomie relaxante peut être partielle, dans le cas, il faut respecter plusieurs impératifs, parmi lesquels, donc, vous voyez ici, donc, il y a une traction qui ne s'étend pas par les manœuvres habituelles. On va faire rangée d'endodiathermie qui va s'étendre jusqu'à la rétine normale. Attention, lorsqu'on va aborder la rétine normale, parce qu'on peut léser facilement la choroïde, donc on va utiliser les pointes de ciseaux pour enlever avec délicatesse la rétine, ou bien pique-membrane pour enlever et couper. Et vous voyez que on va utiliser plus d'endodiathermie dans la région où il y a beaucoup de vaisseaux pour éviter donc le saignement péropératoire. Et vous voyez en bas qu'après réapplication, donc il y a vraiment une dilatation centrale de cette partie qui était contractée. Maintenant, dans les rétinotomies relaxantes circonférentielles partielles, Donc, vous voyez, lorsqu'il va affecter une région très importante, il faut donc se rappeler qu'il faut aller jusqu'à l'aura serrata et parfois, d'une façon oblique, on va peut-être adopter donc les manœuvres de l'ATZ ou bien donc, et rentrer dans une zone de rétine normale pour éviter le redécollement post-chirurgical. Ici, on va voir comment faire une rétinotomie circonférentielle partielle sur 360. Ah, donc, voilà. Je vais couper la musique. Si on va voir comment faire une rétinotomie circonférentielle partielle sur 180, après avoir marqué avec l'endodiathermie, avec donc des traits de refend dans la zone de rétine normale et vers l'aura, on va faire donc, voilà notre rétinotomie entre les deux. Voilà, pour éviter le saignement. On l'a fait au vitréotome, mais on peut la faire bien sûr au ciseau. Donc, les ciseaux permettent une coupe vraiment plus fine. Les bords sont encore épaissis, on va remédier à ça. On va enlever donc une petite partie des bords. Quand même, je vais assister par une rétinotomie radiale ici, voilà, pour soulager les bords. Et on va donc utiliser la perfluorocarbone pour aplatir la rétine. Et la rétine là, on va compléter par l'onde laser et les échanges. Et le tour est joué. La rétine est là. Parfois, on utilise la rétinectomie radiale, comme vous voyez sur l'image. Parfois, on est obligé de faire une rétinectomie sur 360. Et là, il s'agit d'un sujet de 37 ans, en traumatisme ancien, qui se présente avec PL positif, une cataracte, vous voyez un décollement très important. Après une vitrectomie gracieuse, on va enlever tous les membranes et PVR et on constate que la rétine elle est tellement contractée dans la périphérie, donc on a opté pour une rétinotomie relaxante sur 360. Après l'endothéatromie, voilà, on a libéré la rétine tout entière et on va donc faire une radiale pour décontracter en plus la rétine. Et on va prélever les mailles de prolifération sous-rétinienne tout entier. Injection du perfluorocarbone, la rétine elle est totalement aplatie. On va enlever toute la partie de la rétine antérieure, source de complications néovasculaires. Et là, Hera et joignent Dr Mortada. Je fais donc le pelage de la limitante interne sous PFCL et l'onde laser sur 360 et la rétine elle est à plat. Donc, bien sûr, les échanges fluide air, puis PFCL air, puis donc silicone air, l'état final, l'état initial, et voilà l'état final. Les complications de la rétinectomie il y en a beaucoup de complications, donc péropératoires et non post-opératoires, soit l'hémorragie, soit difficulté de réattacher, ou bien le slipage lors des échanges, le déplacement de la macula, et en post-opératoire, l'hypotonie qui est vraiment une complication majeure qui peut donc empiéter sur le pronostic, donc atteindre du champ visuel et le redétachement ultérieur. Donc, il importe de rappeler donc quelques résultats des études Silicon Study, l'ancienne étude, qui a rapporté qu'après rétinectomie, 50% il y a de redétachement avec une acuité visuelle inférieure à 5. Mais dans les études récentes, donc dans le groupe, dans l'étude rapportée par Eckhart, il n'y a que 9% de redétachement. Et donc, il n'y a que 7%. Vous voyez donc avec l'amélioration des techniques et des connaissances, il y a de moins en moins de complications et de plus de gains. En conclusion, la rétinotomie et la rétinectomie peuvent améliorer l'effet thérapeutique des décollements de rétine, compliqués dans le cas de PVR. Il existe de nombreuses indications de rétinectomie imposant une bonne connaissance de l'ordre de la prise en charge pour être efficace. Et les complications de ces manœuvres sont élevées et doivent être gérées correctement. Donc, merci.
Merci beaucoup, Dr Shamil, pour cette belle présentation et très didactique. J'ouvre la discussion. Si on a des questions de l'audience ou du panel.
Let me tell you only one thing. I love to hear Hooke's law. This is the Hooke's of elasticity. Hooke's lived when Isaac Newton, he described the law of elasticity. And this is the main reason why I continue to use buckles to maintain the periphery, even if I cut the retina. I love to, Shamil, to mention Hooke's law. This is a wonderful law of elasticity. Yeah. Thank you, Shamil.
Thank you.
Alors, Dr Shamil, on a une question de l'audience. Pour l'échange fluide-air en cas de rétinectomie sur 360, est-ce possible ou pas?
Fluide. Attends, donc lorsque on a rempli donc la partie postérieure par le perfluorocarbone, la partie antérieure elle est remplie par bien sûr le BSS. Donc on va commencer par l'échange fluide. Ce BSS antérieur, on va l'enlever par rapport à l'air. Donc on va insuffler l'air et enlever cette fluide là. Et ce n'est qu'à enlever tout le BSS qu'on va commencer à enlever le PFCL pour éviter le slippage au maximum. Parce que là, sur les bords antérieurs de la rétinectomie, c'est de là que va glisser donc la rétine. Sinon, il y a certains qui optent, moi j'opte sur cette méthode. Je fais donc fluide air, donc perfluorocarbone against donc, l'air. Par la suite, je fais donc enlever donc l'air, puis je remets du silicone. Mais il y en a qui font directement donc l'échange PFCL silicone, d'accord?
Parfait. Très bien.
I have a question for Dr. Shamil.
Yes.
How do you prevent the rotation of the retina after doing the 360 degrees retinectomy?
Yes.
Does it impact the visual acuity if it's rotating these cases where the retina is really is poorly viable, let's say?
Yes. Lorsqu'on fait donc la rétinectomie sur 360, donc elle est commune qui se produit une petite rotation, voilà, une petite rotation de la rétine. Donc, on doit donc veiller à repositionner. Donc, on repose soit par les deux pinces, mais quand même, ça va être traumatique. Si on utilise le backflash et la partie soft du backflash siliconé, donc on peut quand même donc faire une petite rotation, d'accord? Et parfois, c'est très difficile. Attention, parce que peut se faire ce qu'on appelle un twist de la rétina. Donc, on peut faire la coupe par des ciseaux, faire des rétinotomies radiales pour encore décontracter cette rétine. Et attention, donc, les rétinectomies radiales peuvent se prolonger vers le pôle postérieur, ce qui sera néfaste par la suite. Donc, utiliser donc, le PERL, c'est utiliser donc, le backflash pour faire cette petite rotation de la rétine sans l'atteinte du structure sous-jacente.
Je peux dire un petit mot?
Oui.
Juste une petite astuce, Shamil, pour éviter les rotations. Parfois, on peut laisser une partie de la rétine, c'est-à-dire tout couper, et laisser juste un petit endroit de la rétine qui maintient, même parfois en deux endroits, ça permet de stabiliser. Et une fois qu'on a mis les perfluorocarbones liquides, eh ben c'est là où on coupe, parce que ça y est, la rétine est stabilisée, mais à condition de faire un échange PFCL silicone directement, parce que quand on passe à l'étape R, on ne gère plus réellement la rétine qui est derrière, et vraiment, l'échange PFCL silicone, je pense que c'est ce qu'il y a de mieux, et il faudrait essayer. C'est très simple et c'est beaucoup plus rassurant dans cette chirurgie difficile, parce que le moindre passage par une période d'hypotonie, on a la berge de la rétinectomie qui commence à saigner. Et donc, il faut vraiment veiller à ce que la tension oculaire reste élevée pendant toute cette période d'échange.
Yes, Dr. Mortada.
Dr. Mortada.
Yes, I would like to comment on how to prevent rotation of the retina during 360 degrees retinotomy. And if it is possible to keep the retina hinged in one quadrant or to a point at one clock, this will prevent rotation of the retina. So if you keep it hinged to one point and then you inject PFCL and then you cut this hinge at the last step. And this way you may help to keep the location of the macula unrotated. Otherwise, you can rotate it under PFCL using soft tip instrument or a soft tandem scraper.
Okay.
Are there any comments? Yeah, Dr.
I
Jorge?
had a comment, and I'm sorry because my French is not really good, so I missed a lot of the subtleties. So so sorry about that. Perdón. But I do have also intentionally a contrarian point that I wanted to make, and it's about laser. I saw that you did quite extensive laser on your after your retinectomies. I don't have any data for this, but so I will tell you upfront that this is an opinion, not a scientific-based decision. But I think that laser is yet another injury that's performed when you perform a retinectomy. In this, Carlos, I'm sure is going to agree that you are performing an injury to the retina. And that's the one thing I go against myself in the concept, because I mean, Dr. Hassan mentioned, yeah, you can't fix from the inside, from the outside what's on the inside. But the one point is that when you perform any retinectomy, you are creating an injury to the retina that in and of itself is going to create more PVR stimulus. So one of the reasons is you want to retinectomize the remaining part of the retina. But then I was talking about laser. I believe that minimal laser creates less damage to the retina than extensive laser. And so I limit the amount of laser that I perform. And sometimes, even with a great final outcome of your surgery, there will be contraction after the surgery, and the retina where you finish will not be where it is a month later. So I think that when you create laser, quite abundant laser particularly, you may be fooling yourself telling you that retina is going to stay there. It's going to be pulled, okay? And so I try to perform less laser, only as minimum necessary on the edge of the retinectomy, and I'm done. And in certain cases, I may even avoid the laser, leave the silicone oil later, and then once the thing stabilizes, then I'll perform the laser with the hope of removal of the oil when possible. I know it's a different opinion, but it's just, as I said, no scientific database, but an opinion. I'm curious your thoughts about that.
George, I
Great.
agree with what you have said, and I think extensive laser is not required. So we try to make the minimum amount of laser because laser excites inflammatory reaction, maybe a source for a reason for postoperative hypotony. So I think the minimum laser to the edge of the hypotony is strongly recommended, and try always to avoid the long posterior ciliaries because in order to decrease the risk of anterior segment ischemia.
What is the definition of minimal laser? Like 1, 2, 3 rows? What's the distance between any laser?
Maybe three rows of laser may be sufficient.
Yeah. Yeah, along the edge of the area.
And try to leave the space between the laser. So I hate using the continuous laser. So I use the scattered laser, leaving a spot size between each application. I think this is more healthy for the remaining retina.
And the other part is that you already have a compromised peripheral visual field, and the more laser you perform, the more retina you're destroying and the more peripheral field that you're destroying. So, of course, the peripheral field is it's not as important, but I just try to be careful not to overtreat it.
Because we talked about postoperative PVR, I would like to know what's your opinion about methotrexate intravitreal injection to prevent postoperative PVR, because there are some studies right now. Do you have any experience with that for the panel?
Yes, I had experience in trauma cases, and unfortunately, my experience is not positive. I know that there are research from Christopher Riemann that he is using methotrexate to decrease the post-operative proliferation, but I tried it in trauma cases, and I'm not impressed.
Okay.
I think there's an important question here.
Maybe this is a limited experience, but I have no positive experience.
This is more of a biotechnology question, because methotrexate is a very blunt instrument, and you're talking about, you know, a chemotherapeutic agent. Eventually, we will have biological agents, just like we have Avastin, that are going to be directed towards the attachment point of cells. It's not the cells that matter; it's where they attach and where they contract. So that is important. The problem that we have, unfortunately, is that us here feel that PVR is a major problem, but in reality, it's not a huge economic problem. And biotechnology companies don't want to spend the amount of money that is required to find something that we think could be feasible. If you think about it, and if you pull back from PVR is scarring. And scar formation is something that happens in any field of medicine, in any field of surgery, from plastic surgery to gynecologic surgery to retina surgery. And it's one of our unmet needs, our inability to control scar tissue without damaging the underlying important cells and tissues that we treat. And it's an unmet need beyond retina, but I do think that we need to, as much as possible, communicate this to the biotechnology community and recognize that there is a market, financial market, that they can explore in these fields.
Great idea. Thank you. So that was a great talk and a great discussion. So please join me in welcoming our next speaker, Dr. Carlos Mateo, who will give a talk on management of macular faults after retinal detachment surgery. So Dr. Carlos Mateo is a founding partner and ophthalmologist specializing in the retina at the Ocular Microsurgery Institute in Barcelona. He is also an associate professor on the master course of retina and vitreous run by the IMO and the Faculty of Medicine at the University of Barcelona, and part-time teacher on the retina modules at the ISASO. So he's an active member of many societies such as the American Academy of Ophthalmology, EURETINA, ASRS, and he has been invited guest speaker in more than 40 prestigious meetings all around the world. So Dr. Carlos, thank you for being with us today.
Thank you, Yassine. Thank you, Sarah. Thank you, Mohammed, for a kind invitation to participate in your meeting. It's a great to meet good friends and to discuss, you know, how we manage. You know, there are many ways to do things. And you asked me 7 minutes about, you know, preventing and managing dry macular folds. This is not a very, very often complication, very frequent complication, but, you know, you have to know how to deal with it. You know, let me tell you that perhaps macular folds is a serious but underreported complication after retinal detachment surgery. When this fall affects the fovea, not the macula, the fovea, falls induce symptoms, linear scotoma, metamorphopsia, visual field defects, and they have if you take a look in the literature, you will find different natural histories, from resolution, visual recovery, to permanent damage and visual loss. You know, let me tell you something I learned, because, you know, I became an expert in macular folds because I did a lot, you know, a huge number of limited macular translocation that was described by Jean de Juan. Let me tell you first, macular folds tend to disappear over time. Look at this case. You know, I operated in 2001, and many years later he improved because the fold was not in the fovea, and you know the foveal folds, the retinal folds disappear. Then when they are not in the fovea, they may be asymptomatic. Which are the risk factors to have a macular fold? You know, the first is the use of gas. If you use gas, you have a risk to have a macular fold. circumferential buckles. Many people say, okay, you put buckles, you have a high risk of macular fall. Look at to the right. You know, in the first case, many of them, the inferior and left is mine. It was a limited macular translocation. Superior is after buckle and vitrectomy for giant retinal break, retinal detachment. In the upper and right, you will find a radial sponge and gas after Plana vitrectomy for a bullous retinal detachment, after normal retinopexy, after limited macular translocation, this is a case of mine. And down and right, you see after inferior retinal detachment, because the inferior retina is over superior retina. Then, you know, there are causes for this. You know, the third thing is the slippage of the retina following, for example, giant retinal tear. Let me tell you, the worst case is when you have a superior bullous retinal detachment, especially when the break is only superior at 12, for example. Let me tell you another thing that this is very important. You never, ever remove all the subretinal fluid in a retinal detachment surgery. You can use perfluorocarbon liquid, or you can use a posterior retinotomy. You never remove all the subretinal fluid. This is the case I tell you for all the young people. This is the worst case. You know, you say, okay, this is a bullous retinal detachment. I see only a break at 12. Even I can avoid to use a buckle. That's great. You know, but you know, the line of the detachment is just in the fovea. This is the worst case. This case is a high risk to have a macular fold. Look at this case. This happened to a colleague of mine, and you know, bullous superior retinal detachment. The surgeon, performed a 3-incision buckle. Look at the line. Where is the line of the retinal detachment? Is just in the fovea. And after the treatment, the patient developed this macular fold, and we have to treat it again to open the macular fold. This is not very complex, but this is a, very disturbing, complication. Let me tell you two tricks. There are many, but let me tell you two tricks. Let me tell you two tricks about how to avoid the macular fold. Try to remove as much as peripheral fluid as possible. Again, it's impossible complete removal of the subretinal fluid. Impossible. Even you think that you did it, believe me, you won't be able to remove all the fluid. In some cases, if you have a peripheral break, it's useful to perform a more peripheral hole, to remove much more fluid and to avoid a large quantity of fluid going to the macular area again. And the second thing is to use the steam roller. Put the patient toward the breaks. Imagine in this case, I'm showing you, there are two breaks in the temporal side. The border of the retinal detachment is crossing the fovea. Then, yes, when you finish the surgery, you put the patient toward the breaks. Don't forget the tamponade now. You are milking the subretinal fluid to the break, just to, avoid fluid under the fovea. Then you put face down or whatever. All the folds you have to treat, after, look at this. This is a patient that, they did, a buccal and vitrectomy for a retinal detachment. There is a perfluorocarbon liquid, as mentioned Jorge, in the, in the fold. Do we have to treat this fold? Patient was 0.7 vision, has submetamorphopsia, that's true, but look at the fovea in the vertical scan. The fovea is not affected by the macular fold. And, you don't have, in my opinion, you don't have to treat it. And in fact, this patient, some years later, have 20/20 vision, 20/25 vision, fold disappear, and the fovea has a normal configuration with all the layers. Look at this patient. As a patient was operated in another city, but this patient is very, 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 very consternated. Was very consternated because of this, and he went to many surgeons in Spain, vitreoretinal surgeons, and many surgeons told him, "This is an emergency. You have to treat this fold." Visual acuity at this point was 0.4, but look at this, the OCT, the horizontal scan is normal, the fovea is normal, and the vertical scan, the macular fold was not in the fovea, was just juxtafoveal. Then I remember a paper was published in Spain, many years ago, that a friend of mine published this paper. And in the beginning I said, okay, this is not true. You know, he explained, I mean, the case is true, of course, but I thought, you know, this is that the retina, you know, atrophy, you know, no, it's not true. I grabbed the two images and the retina moves. Remember that, you know, after a retinal detachment, the retina moves in near 63% of the cases. You know, was published by a Japanese group many years ago. But if you read the paper, there is one sentence that struck to me, you know, was the retina may return to its original position. You know, the retina may try to go again to its original position. Look at this. I grabbed the two pictures of this patient that was published many years ago, and I overlaid these two pictures, I put the inferior vessels to avoid rotations. You know, the retina moved spontaneously 480 microns up. And this explains why this patient went to 20/25 vision, because the fold didn't really affected the foveal area. Coming to this patient, you know, I did the same. I wait. Now the patient is 20/25 vision, slightly metamorphosia, many retinal detachment, and you see down and right the movement of the retina downward. Then, if the patient has no foveal fold, perhaps you don't need to redetach the retina and to do what I'm going to show to do. But when you have this, and this patient, this is very strange, because you know, I received this patient many years ago, because the inferior retina was over the superior retina. What happened? This was perhaps an inferior retinal detachment, and they left the patient looking to the ceiling for 1 hour. Then all of the fluid went down the macula, and the redundant retina went over the fold, and you can see. Then let me show you what to do when this happens. You know, this is another case. This is a truly foveal fold. This acuity was very poor. And look at this. The technique is very simple. I use laser to mark my retinotomies. You don't need it. You don't need it. Then I inject the mid-periphery. Remember that when you inject the mid-periphery, the fluid is going to go to the periphery. Then it's not to go, you know, to the macular area. Then we make a fluid exchange. The bubble's going down. Then we detach the macular area. We confirm that the macular area is detached. Then with perfluorocarbon liquid, we attach the retina. And this is an agnesia technique. You stain under perfluorocarbon liquid to remove the internal limiting membrane. There is no scientific data, but I prefer always in this case to remove this. Look at this, another foveal, pure foveal fold, very poor vision and distortion. And then I stained before. I'm going to show you now. You see the stain of the internal limiting membrane. This is an old case. And then I began to inject in the mid-periphery. Then I make these bubbles to join in the posterior pole, trying to detach the macular area, perfluorocarbon liquid. You see, this is white lines because these are the opening of the inner parts of these folds. Then I remove, of course, I strongly advise to remove the interlimiting membrane. In this case, remember, this is the toughest, the most rigid part of the retina. This is the aspect after the surgery. Don't wait too long. Don't wait too long. This is another patient that was operated elsewhere, a myopic patient. I did the same, but you would see was 1 month before the macular fold. And look at this, how difficult it is to separate the inner part of the retina. Then with the finesse, we separated the inner part of the retina, then perfluorocarbon liquid, removing the internal limiting membrane. As you can see here, it's very easy under perfluorocarbon liquid. And look at this. This is the final aspect of this patient. These are some patients I continue to see. These are 10 of them, but you know, I had some of them when I was after limited macular translocation. The first and the second case were after limited, there were cases of mine. I did this and I had to retreat them. Only 2 of these cases ended with a very poor vision. The others, you know, ended with a very good vision. You know, foveal folds after retinal detachment surgery, for me, there are 3 important points. first, recognize the high-risk cases. When you have the line in the fovea, be careful. You have a high risk to end with a macular fold. Use the steamroller. Always rotate after, when the patient goes out from the OR, rotate the head towards the breaks, trying to milk, this subretinal fluid to the breaks, and don't accumulate residual fluid in the foveal margin. But if the falls clearly affects the fovea, don't delay treatment and treat them. And that's all what I wanted to share with you. Let me stop the sharing screen and that's done, I think. And okay.
Thank you, Dr. Carlos. What a great presentation.
Thank you. Thank
Full
you.
of tips and tricks to prevent and manage postoperative macular folds.
Yeah.
Hola, Carlos.
Hombre, ¿cómo está? Excuse me.
Carlos, mira.
This is Peru, right? Peru.
This is Peru. Right. Yeah, this is Peru. So,
great.
By the way, everybody say hi to our team in Morocco.
Hi there.
Great. My friends,
here,
great.
We've been watching your beautiful surgeries, and I commend you for such beautiful work. Y tenemos que dejarnos porque ya viene la comida.
Sure, they have to eat now. They have dinner now. Yeah, okay. La comida, lunch. You're having lunch now. Okay. Okay, enjoy. Bye, friends. Bye, enjoy.
Buena foto. Ahí está.
Thank you, guys.
Hablando de microscopio, una vez observé algo que fue muy gracioso.
Does the panel have any questions or comments about how to manage postoperative macular folds? Or even prevention?
Hi, I have a question.
Ahmed, how are you?
Right. Hi, Carlos. This is an amazing presentation. So lovely. I think just my question really is about the prevention. I always feel that the macular fold happens when patients sit up. And I think the critical time in my mind is like the direct after the surgery. So I feel maybe the best position, again, in my mind, and that's what I do, is I leave them flat on their back. They don't sit up whatsoever, even if they're going to wake up from general anesthesia or if they're under local. They stay flat for an hour to an hour and a half. Then they sit up and go. Because in my mind, it's just this even small time of sitting up that will cause a problem. Another point as well for your comments on these 2 points is I feel if the gas is going to steamroll, then you have to underfill the eye with the gas. But I feel if the eye is really filled with the gas, then it will not be able to steamroll. So
you mentioned a very important point, Ahmed. The position, I don't fully agree. The problem is that if you have an inferior retinal detachment, you are face down, you are closing the break, and you're pulling all the fluid down. Then if you sit the patient, the gas is going to press the fluid towards the breaks inferior, then the retina is going to be down. But
face down, face up, so supine.
Face up, yeah, look in the ceiling. Look at the ceiling,
Correct.
But the breaks now are in the ceiling, and then you are compressed, milking all fluid to the macular area. But I fully agree that perhaps you don't need to fulfill the eye. The other thing I think is when you have this high risk, for me, the high risk is 12, break at 12, and then the line in the fovea. If you sit the patient, yes, after the surgery, all of this fluid is going to be in the macular area. And then you are pressing the retina is going to be attached, and then this fluid is going to be there. Then for these patients, perhaps another thing you can do is detach a little bit more the macular area, just to avoid this stop of the detached, non-detached retina. Then perhaps, making a partial fluid exchange, you perhaps are able to detach a little bit this stop, and then perfluorocarbon liquid to, iron the retina again. But, again, there are a small case, there's a small number of cases, but, the worst is superior break at 12 and the line in the fovea. This is for the young doctors here in Morocco. I think this is for experienced doctors because you have a high risk to have it.
So you don't recommend using systematic PFCL to dry as much as possible the macula?
No. I always use PFCL, but you won't be able to remove all fluid. If you take a look in your, in your lens, you will see how when you make the final fluid perfluorocarbon liquid air exchange, you will see how there is fluid going to the macula that will be accumulated in the foveal area.
It's impossible to dry.
Impossible to dry. If you see a lot of fluid, then you can stop and inject a little bit again perfluorocarbon liquid that you have remnants in your syringe to put again up and to drain again and to try to go down. But if you have fluid, you place to the side and face down, just trying to press the fold, just to press the fluid.
So do you have also an alternative technique when we don't have the 41 gauge needle? Because it's not always available in our settings. Can we do retinotomy and with the vitrector? Is it safe for the retina?
The problem is that you have to detach the retina. If you make a huge break or a large break, then it would be very difficult. Perhaps with a soft tip, you can go there and inject fluid, but it's not that easy to detach the retina. Another thing is don't inject into the fold. Because if you inject into the fold, some folds go to a periphery. And if you inject to the fold, the fluid is going to be in the periphery, and you are going to detach the peripheral retina. If you want to detach the macular area, at the end you have to make a fluid exchange, and then all of this subretinal fluid go down, and then perfluorocarbon liquid and to remove the interlimited membrane.
And as I've seen, you never inject in the macula, always beyond the arcades to prevent macular hole.
Yeah, because it's the thinner part of the retina, and perhaps if you inject very slowly, perhaps you don't have risk. But I had some macular holes in subretinal hemorrhage. This is totally different, I know, but I have some of them when you inject so near the foveal area.
Okay, thank you.
Okay,
Great presentation, great talk.
Okay, we'll pass now to the next presentation, talking about diabetic vitrectomy, which itself is a surgical challenge, and vitreoschisis makes it even more complicated. But this is not the case when it's in the hands of a surgeon as competent and talented as Dr. Bennani. Dr. Bennani is a vitreoretinal surgeon based in Casablanca, and he is the current president of the Moroccan Society of Ophthalmology. He has been always a major supporter of young ophthalmologists, and we are really very honored and pleased to have him with us. We will learn a lot from his presentation on the topic of vitreoschisis and diabetic vitrectomy. Dr.
Hello, everyone. First of all, I would like to thank you for your invitation. It's really nice to see the enthusiasm and the energy of young Moroccan ophthalmologists. I hesitated between speaking in French or speaking in English. And finally, I decided to speak an universal language, surgical language, but I'll do it in French. You asked me to speak about surgery of diabetic retinopathy. Et donc, je vais démarrer par vous dire que je n'ai aucun conflit d'intérêt. J'ai laissé les diapositives en anglais. Il y a différentes techniques chirurgicales pour opérer un diabétique, mais le but est le même, enlever la prolifération fibrovasculaire pour dégager la rétine et dégager l'axe visuel. Il y a différentes techniques. On peut segmenter, on peut délaminer, on peut disséquer en bloc. Ceci dépend de la sévérité de la situation, de l'expérience du chirurgien, de ses habitudes aussi, mais très souvent au cours de la même opération, nous faisons un mix des trois techniques chirurgicales. Avec ces nouveaux vitréotomes, on peut faire, c'est de véritables couteaux suisses, on peut faire un tas de choses. Ici, on l'utilise comme une pince, ça permet de tirer la fibrose et la décoller. Et quand il y a une adhérence solide, on l'utilise comme vitréotome, comme ciseau dent qu'on coupe. Et on peut enlever de grosses quantités de fibrose, comme on voit sur cette séquence accélérée.
mais à condition que le petit bout du vitréotome puisse entrer entre la fibrose et la rétine. Mais que faire quand, dans les formes graves, où l'adhérence est tellement solide qu'on ne peut pas rentrer le vitréotome, le bout du vitréotome, entre la fibrose et la rétine? Quelle est la relation entre la fibrose et la rétine? C'est une question importante si on veut comprendre ce qui se passe dans la rétinopathie diabétique. Je vais commencer par une observation chirurgicale. Ici, vous avez une hyaloïde postérieure qui est tendue, que l'on voit ici. On va faire un trou avec le vitréotome dans cette hyaloïde. On va aspirer le sang rétrohyaloïdien, ça permet d'améliorer la visibilité. Et on va ouvrir cette hyaloïde postérieure sur 360 degrés pour désolidariser complètement cette fibrose de la périphérie, pour qu'il n'y ait plus de traction. Quand on travaillera en arrière sur la fibrose, on ne tirera plus sur la périphérie. Voilà, donc on a désolidarisé cette fibrose postérieure et on plonge au niveau de la rétine. Et qu'est-ce qu'on voit? On voit cette prolifération fibrovasculaire que vous voyez ici, qui est très adhérente à la rétine, et on va, avec une pince, sonder en quelque sorte cette prolifération, cette fibrose, et on va finir par trouver une très fine couche ici, que vous allez voir, qu'on va tirer avec la pince, et quand on décolle cette couche, ça permet de faciliter grandement la chirurgie de la rétinopathie diabétique. Vous allez voir, on va finir par enlever toute la fibrose sans quasiment toucher à la fibrose, on y touche indirectement en tirant sur cette deuxième couche. Voici encore un exemple sur une vieille vidéo vin gauche où avec la canule de Charles à embout siliconé, on essaye de rentrer, mais impossible de rentrer, même pas cette petite spatule. C'est une vieille vidéo, on n'utilise plus ces spatules, ou très peu, et on va, à distance de cette fibrose, retrouver une fine membrane, la même que celle de tout à l'heure, et on va la soulever, et le fait de soulever cette fibrose va nous permettre de faire le tour tout autour de la fibrose, et encore une fois, d'enlever cette fibrose grâce à l'ablation de cette très fine membrane. Et quand il y a des adhérences, on va les couper au vitréotome, au ciseau, les unes après les autres, et on finit par enlever toute la fibrose. Alors, la question qui se pose, à quoi correspondent ces deux couches? Quand on a ouvert une première couche, on se dit, ça y est, c'est fini, il n'y a plus rien d'autre, et on trouve une deuxième. Ça correspond au vitreoschisis diabétique. C'est une notion très importante pour comprendre la chirurgie du diabète. En fait, la hyaloïde postérieure se clive en deux. Une partie antérieure qui se décolle et une autre qui reste collée à la rétine. Donc, on a un mur antérieur et un mur postérieur du vitreoschisis. Ceci a été pour la première fois et quasiment la seule fois, il y a très très peu d'études sur la question, décrite par Grégor en 1996 sur une série de 179 patients. Il avait retrouvé dans 81% cette petite membrane, et les études en immunohistochimie avaient démontré la présence d'un collagène de type 2 qui est exclusivement vitréen, donc il s'agit bien de vitrée et d'hyaloïde postérieure, c'est-à-dire le mur postérieur du vitreoschisis. Sur une série personnelle de malades opérés en 2017, sur 180 cas de malades avec une fibrose importante, une fibrose, on avait 123 membranes additionnelles, c'est-à-dire 68%. Donc, en gros, chez les diabètes graves, avec grosse prolifération fibrovasculaire, 2 malades sur 3 présentent ce vitreoschisis, ce clivage du vitreoschisis, ce clivage de la hyaloïde postérieure en deux. Mais la question qu'on se pose, comment est-ce que cette fine membrane, très fine, la hyaloïde postérieure, peut-elle se cliver en deux? Puisque le clivage, normalement, quand ça tire derrière, il se fait entre la hyaloïde postérieure et la limitante interne. Mais chez le diabétique, tout le problème réside à ce niveau-là. Il n'y a quasiment jamais de DPV complet et l'endroit du clivage est anormal. 1% des cas seulement de DPV total chez les diabétiques. Et quand on a la vidéo ne veut pas marcher, on va réessayer. Voilà, ça marche toujours pas. Donc on a, quand le DPV est total, il y a rémission de la rétinopathie diabétique. En l'absence de contact entre la hyaloïde postérieure et la rétine, la prolifération fibrovasculaire ne peut plus se développer et donc il y a rémission de la maladie. Le plus souvent, ce qui se passe, en fait, c'est un DPV partiel. Donc, on a la hyaloïde postérieure qui se décolle, comme vous le voyez sur la petite animation, mais qui reste collée en plein d'endroits à la rétine. Et ces endroits-là qui vont servir d'échafaudage à la prolifération. Donc, le site de clivage est anormal. Il se produit, comme je l'ai dit, exceptionnellement entre le cortex postérieur et la limitante interne. Alors, où est-ce qu'il se produit? Il peut se produire quand ça tire beaucoup, il peut se produire entre le cortex, entre le complexe neuroépithélium, entre le complexe cortex et neuroépithélium et l'épithélium pigmentaire. Et c'est ce qui va donner le classique décollement de rétine tractionnel. Malheureusement, ça ne marche pas. Donc, on a le décollement de rétine tractionnel que nous connaissons très bien. Ça peut se décoller au sein même de la rétine. Donc, on a une rétine interne qui se décolle et une rétine externe qui reste décollée, qui reste collée. Et ça, c'est le fameux Vitreoretinal tractionnel diabétique. Et enfin, quand ce clivage se fait plus antérieurement, il va se faire au sein même du cortex. Donc, on a un mur antérieur qui va se décoller et un mur postérieur que vous voyez ici par les flèches qui va rester en place et qui va rester collé à la rétine, comme on peut voir sur les bonnes échographies. Voici ici, vous avez le mur antérieur qui s'est décollé et vous avez un mur postérieur qui est ici. Et ceci est le vitréoschisis. On le voit bien sur les échographies. Quand on a la chance d'avoir de bons échographistes, on voit bien ici ce clivage en deux. Et ceci nous ouvre donc la voie vers la notion de plan chirurgical. Quand on a le plan chirurgical, on n'a plus de problème de chirurgie. Ici, on a traversé la hyaloïde antérieure et ici, il ne faut pas aller attaquer là, il faut aller disséquer derrière. Il faut couper, c'est là en fait, c'est pas ici qu'il faut attaquer, c'est ici, une fois qu'on a enlevé ce mur postérieur du vitreoschisis. Comme on peut le voir ici très nettement sur cette belle échographie, c'est pas là qu'il faut disséquer, il faut disséquer ici, plus en arrière. Sur cette petite animation, supposez que ça c'est la fibrose, c'est pas ici qu'il faut enlever la fibrose, en fait il faut aller à distance et on prend le mur postérieur et la fibrose est dessus. Une fois qu'on enlève le mur postérieur, la fibrose va partir très facilement. Le point d'entrée dans le plan chirurgical est important. Et quand on était en vin gauche, on se régalait parce qu'on avait ces fameux ciseaux courbes que vous n'avez probablement pas connus, que les jeunes n'ont pas connus, et qui avaient la courbure de la rétine. Regardez, on rentre entre la rétine et la hyaloïde postérieure, le mur postérieur, et on arrive à délaminer, à disséquer. Et dès qu'on soulevait cette couche-là, eh ben, vous allez voir la fibrose part rapidement. Voici un autre cas. Ici, on est en train de sonder la fibrose, on la sonde. Quand je tire sur cette fibrose, ce n'est pas pour l'enlever. Je sais que je n'arriverai pas à l'enlever parce qu'on n'est pas sur le plan chirurgical. Je la tire pour voir si, par chance, à distance, on va trouver quelque chose. Donc, je n'ai rien trouvé en bas, je vais en haut, et en haut, je tire, et vous allez voir, il y a quelque chose qui va se décoller ici, là où il y a ma petite flèche, et on va la soulever avec la pince. Et cette grosse fibrose qui semblait difficile à disséquer, on va pouvoir, maintenant qu'on est dans le bon plan chirurgical, c'est-à-dire dans l'adhérence physiologique entre la hyaloïde postérieure et la limitante interne, l'enlever très facilement. Voici encore un cas où, même dans ces petites fibroses, vous pouvez enlever de grosses quantités de fibrose et vous arrivez sur un petit îlot et vous bloquez. Sachez que là, quand vous bloquez, il y a encore un problème de mur postérieur. Et là, voilà, je viens de décoller ce petit mur postérieur, on l'a individualisé, et on fait le ici. Là, ce n'est pas la fibrose que je tire le mur postérieur qui est là. Il faut voir juste à côté, juste à distance. C'est souvent juste à côté de la fibrose, mais pas sur la fibrose elle-même, parce que sur la fibrose, qu'est-ce qui se passe? Le mur antérieur recolle avec le mur postérieur et on a une seule hyaloïde. Ici, je vais en inférieur, même chose, vous le voyez, il se prolonge assez loin en inférieur, on fait le tour. Et une fois qu'on a trouvé ce plan chirurgical, vous allez voir, on enlève la fibrose facilement avec le boudin qui était dans la papille. Encore un exemple, bon, c'est pour ça que je vous ai dit langage universel, il y a plein de vidéos qui parlent d'elles-mêmes. Ici, avec le vitréotome, on se sert du vitréotome comme une pince. On tire avec le vitréotome, on se met en aspiration seule, on tire doucement, et on voit qu'on a, avec le vitréotome, individualisé le mur postérieur qui est ici. Voilà, vous le voyez. Et l'avantage du vitréotome, c'est que contrairement à la pince, s'il y a une adhérence solide, on peut la couper tout de suite. On n'est pas obligé de sortir, de rentrer le vitréotome ou les ciseaux pour couper. Donc voilà, on va ailleurs, on va soulever comme une pince. Il y a une petite adhérence, on la coupe et on avance. On peut tout faire au vitréotome parfois. Il ne faut pas avoir d'obsession. On a plein d'instruments, la pince, les ciseaux, le vitréotome, il faut les utiliser. Utiliser celui qui donne le meilleur compromis. Et là, on va finir en segmentant ces reliquats de fibrose. Encore un cas. On raccourcit autant que possible la fibrose pour pouvoir bien sentir la petite pince à distance. Voilà. Et là, on tire sur cette fibrose. Ça va nous permettre d'avoir ici, comme vous allez voir, le mur postérieur du vitréoschisis. Et comme je l'ai montré à plusieurs reprises, une fois qu'on l'a, ça va plus vite et on arrive à éplucher en quelque sorte cette fibrose. Dans cette situation-là, on est en train de rechercher le mur postérieur avec le vitréotome, on tire, on essaie d'avoir quelque chose d'individualisable et hop, on vient de faire une déchirure. Point important, le jour où on n'a plus peur de faire une déchirure, on s'inquiète moins de la déchirure. On a fait un long pas dans la chirurgie de la rétinopathie diabétique parce que l'important, c'est pas le plus grave, c'est pas de la faire, c'est de la faire, de ne pas la voir, de ne pas la traiter. Et quand on fait une déchirure, on la traite et il n'y a pas de problème. Ici, donc, on continue notre dissection et on va éplucher toute cette fibrose au vitréotome comme une pince, comme on peut le voir ici. Autre situation extrême, les vaisseaux sont tout blancs, le décollement est total et la fibrose est extrêmement adhérente. J'ai passé 10 minutes à chercher un plan que je n'ai pas trouvé. Là, vous pouvez me dire pourquoi vous l'opérez, les vaisseaux sont tout blancs. C'est une autre question, on peut tenir une demi-heure sur les indications très intéressantes et très difficiles de la rétinopathie diabétique. Voilà, donc on revient à la chirurgie. J'ai fini par trouver quelque chose et boum, je fais un trou que vous voyez ici à droite. C'est pas grave, on oublie le trou, on le traitera. Et on va faire le tour autour de la fibrose, tout autour. On oublie le centre de la fibrose. Et vous concevez bien qu'il est impossible de segmenter. Je ne vois pas comment est-ce qu'on peut segmenter la fibrose dans cette situation. Il n'y a pas de place pour rentrer le vitréotome entre la fibrose et la rétine. Surtout une rétine décollée comme ça. On fait le tour sur 360 degrés, patiemment. Ça prend du temps, mais beaucoup moins de temps que si l'on voulait enlever la fibrose en la segmentant, par exemple, ou en tirant dessus. Et voilà, on finit par enlever ce boudin qui était dans la papille et on finit par enlever toute la fibrose. Alors, pourquoi rechercher un vitréoschisis puisque on peut segmenter la fibrose? C'est plus facile, comme je l'ai dit, avec les nouveaux instruments, les nouveaux vitréotomes. En fait, quand on enlève que la fibrose, on enlève la fibrose qui est juste la partie visible de l'iceberg. On n'enlève pas le plus important. Il faut individualiser le mur postérieur du vitréoschisis, disséquer dans le plan chirurgical. Ceci permet d'enlever non seulement la fibrose, mais son support, qui est le mur postérieur du vitréoschisis. Regardez ici dans ce cas, très démonstratif. Donc, j'essaie de trouver le mur postérieur. Je fais un trou que vous voyez ici et qui me gêne énormément parce que quand je tire sur le trou, ça l'élargit. Donc, je me dis finalement, ce cas-là, je vais le segmenter. Je segmente, mais à la fin de la segmentation, regardez le gros nœud, impossible de recoller cette rétine. Et donc, je reprends ma pince, je rentre et je finis par trouver le mur postérieur qui était toujours là. Et je finis par faire ce que je devais faire au départ, mais que je n'avais pas pu faire. Et vous allez voir que maintenant qu'on va enlever ce mur postérieur, les choses vont aller beaucoup plus vite et ça va permettre de décontracter cette rétine. Alors, juste avant de conclure, voici le mur antérieur qu'on a coupé au début de l'opération. Quand je tire sur le mur antérieur, tout vient. Ça, c'est le mur postérieur. Quand je tire dessus, il n'y a que le mur postérieur qui vient. Ici, mur antérieur, toute la rétine vient. Je vais vers le mur postérieur qui est derrière. On épluche parce qu'on est dans le plan, parce qu'on est dans l'adhérence physiologique. Alors, pour conclure, on doit absolument connaître cette notion de vitréoschisis qui est peu connue. On doit chercher le mur postérieur du vitréoschisis. L'ablation de la prolifération fibrovasculaire nécessite l'ablation de son support qui est le mur postérieur du vitréoschisis. C'est pour cela qu'il faut disséquer dans le bon plan chirurgical Et le bon plan chirurgical est entre le mur postérieur du vitreoschisis et la limitante interne. Voilà, je vous remercie.
Merci beaucoup, Dr Bennani, pour cette belle présentation. Et voilà, on ouvre le débat. On a une collègue d'Algérie juste qui dit, je lis ce qu'elle a écrit. Dr Bennani is a great surgeon and a reference in the field. I always enjoyed the presentation since I was a resident. Elle vient d'Algérie, c'est une collègue et actuellement elle est prof assistante. Donc elle te fait un coucou, je te dis ça. Et une autre question de l'audience, qu'est-ce que vous recommandez comme tissu pour pratiquer ces techniques pour les jeunes ophtalmologistes? C'est-à-dire, vu que tu as montré une vidéo tout à l'heure avec, je pense que c'est du cellophane, quand tu mettais comme ça pour montrer que la fibrose, elle était là et au lieu de la chercher, il faut aller chercher la partie qui est un peu moins visible. Si on veut pratiquer ça avant de se lancer dans des yeux...
En fait, ça c'était juste pour comprendre qu'il ne faut pas se concentrer sur la fibrose elle-même, mais sur sa matrice qui est le mur postérieur du vitréoschisis. Et c'est là où ça se passe. En fait, il faut aller vers l'adhérence physiologique parce que entre le mur postérieur du vitréoschisis et la rétine, on est dans l'adhérence physiologique, donc qui est beaucoup plus facilement dissécable. Donc, c'est juste c'est pas la peine de reproduire. Je pense qu'il faut aller plonger directement sur la fibrose, sur le malade.
Parfait. Et il y a une autre question aussi de l'audience. Est-ce qu'il y a des fibroses très importantes devant lesquelles tu vas t'arrêter et tu vas te dire ça, c'est plus opérable ou c'est-à-dire, quelle est la limite de la fibrose?
Il faut enlever la fibrose quand la fibrose est en cause dans les problèmes. Quand vous avez de la fibrose sur l'arcade supérieure avec un décollement tractionnel maculaire, si on n'enlève pas la fibrose, il est impossible de recoller la macula. Il faut absolument l'enlever. Maintenant, si vous avez du sang, vous enlevez le sang. C'est pour ça que vous avez opéré. Tout est bien et qu'en extrême périphérie nasale, œil gauche, donc le plus difficile, vous avez un îlot de fibrose, ce n'est pas la peine d'aller l'enlever. Vous le segmentez au maximum, vous le laissez parce que le rapport bénéfice-risque est défavorable. Par contre, dans le reste, il faut tout enlever quand vous avez un décollement. S'il y a des fibroses extensives, on peut faire des rétinectomies pour enlever la cause de la traction.
Yassine, je pense qu'il a une question. Yassine,
I would like to congratulate Dr. Bennani for this excellent talk. As we can see, your preferred technique is en-bloc peeling, going from the periphery toward the optic disc. So what are your indications or situations where you begin at the optic disc and do an inside-out technique?
Yes, there is one complex situation. Often in the florid form, in the young diabetic retinopathy, very complicated form, where the fibrosis goes until the periphery and we don't find the surgical plane anteriorly, so we can begin our dissection in the optic nerve. We can just track the optic nerve to have something to cut, and we can do a lot of cuts and dissect the posteriorly to anteriorly.
And how far do you remove the vitreous at the periphery? Because it can give some postoperative anterior lobes proliferation and reproliferation. And so do you stop at the mid-periphery or do you go as far as anterior as possible?
It depends on the severity of several cases. If we have just vitreous hemorrhage, I think it's not necessary to remove all the vitreous. You remove what you can remove, what is easy to remove. It's not necessary. I think it's not necessary to perform vitrectomy under indentation. It's not necessary. We remove all we can remove, and for doing a good panoretinal photocoagulation and in the periphery. But in several cases, when we have fibrosis in the periphery, we have to remove everything.
Okay. So does the panel have any comments on the presentation or questions for Dr. Bennani?
I think it's very important to remove all these cortical vitreous that remains attached, because in some cases you can see contraction in the post-op if you don't remove it. And I think this is it's crucial to find this plane, anatomical plane between the new vessels and the retina. I think it's great talk, great talk.
Yes.
Microphone, please, Dr. Ahmed.
Yes.
Yeah.
Yes, hi, Dr. Bennani. This is a great presentation. It's really one of the rare moments where I really regretted not paying good attention to my French lessons, because I really regret missing parts of your presentation.
French if you want.
Well, I really regret now not taking it seriously. I think this is so elegant, and I love that you concentrated on vitreoschisis, because in my view, this is the most important bit really in tractional delamination surgery. I trained with Rob Johnston, who was the fellow of Dan Greger, and Robert always really, this is the main emphasis on the surgery, is the vitreoschisis and getting in the correct plane. So I think it's a very nice and very elegant talk, and thank you so much.
With pleasure.
So are there any other questions from the assistants? Maybe one last question. When you have a iatrogenic break, you have fibrosis around this, and you can remove the fibrosis, what can you do? Do you put silicone oil and?
No. Why we can't remove fibrosis?
Because we cannot find the dissection plane. And we have this iatrogenic break in the fibrosis.
Near the fibrosis, I think we can try on another side. If we have a retinal hole in temporary, we can go to another side to dissect, but it's necessary to remove all the fibrosis when we have retinal hole.
Okay.
And it's not really necessary to put silicone. We put silicone if we have a very large inferior hole, but if it's not inferior, I think it's not necessary to make silicone tamponade.
Thank you. So another great debate we have to conclude. And I am pleased to introduce Dr. Jorge Calzada, who just recorded his presentation because he is in Peru, and who will share with us his experience on actual trends in vitreoretinal visualization and exoscope augmented reality. So Dr. Jorge Calzada graduated from his hometown university in Panama Medical School. Then he completed his ophthalmology residency and retina surgery fellowship at the University of Tennessee and joined Charles Retina Institute as a vitreoretinal surgeon. He founded the Pan American Vitreoretinal Consultants in the Republic of Panama and later the Deep Blue Retina in Memphis, Tennessee. So he has worked with industry in the development of microsurgical tools and digital microscopy. So Dr. Jorge Calzada, thank you for being with us today and enlightening us on how bright is the future of vitrectomy and enhance its visualization. So the talk is yours.
Thank you, everybody. I'm Dr. Jorge Calzada. I am a vitreoretinal surgeon, ophthalmologist. I'm originally from Panama, and my parents are all from Spain, and so there is a historical connection with Morocco, so merci beaucoup. I live and work in the United States in the state of Tennessee, and I'm coming from you right now from Peru because I'm at a conference. I'm speaking tomorrow at a conference in Peru at the Ophthalmological Society of Peru. So, but we're trying to work these multiple continents in a single small world. So I appreciate the invitation. And I'll be speaking to you today a little bit about what I perceive to be what I hope to be perhaps is the future of microsurgical visualization in the operating room. So starting from there, these are my financial disclosures. I've worked for different companies, either as a consultant or for research projects. I think for these presentations, the most important ones are perhaps the bionics, which is, we'll hear about bionics in a little bit, BVI, which is Bionics now partner company, and Heidelberg Engineering, and Bausch & Lomb, which will probably be moving into this space as well. So when you think about surgery and what we do in surgery, I like to think about what are the limits to what we can achieve in surgery. And I'm moving from the big picture to the more detailed picture of surgery. And so when you think about limits to surgical success, one is an important one, which is the intellectual. It's what we learn, how we understand what we're going to do, having appropriate awareness, psychological, situational awareness of the situation that when you're performing any type of surgery. Emotional is a very important one, because there's different personalities between different surgeons, and there are different capacities to handle the emotional aspects of surgery. I've seen great surgeons break down in the middle of surgery, being unable to finish a surgery correctly because of the emotional reaction that they have, particularly when they have unexpected difficulties or complications. Of course, a very important one is training and experience. You can understand what you're trying to do, but if you haven't practiced it, you may not be able to achieve what you're trying to do. Then there's the mechanical, which is how do we handle tissues? And I think when you have big macroscopic surgery, the hand coordination required to perform these surgeries is not as difficult as the ones that we perform when we're doing microsurgical manipulation of tissues under a microscope. When you think about the things that we do in the sub-millimeter space and the micron space, it's quite impressive that we can. And ultimately is the visualization. What can we see? How can we see the tissues that we're working on so that we can perform adequate surgery? So then, if you think about those two last things, one is the mechanical, and the other one is the visualization aspect. And of course, the people talk about hand-eye coordination, but this is a little bit difficult. It's not just coordinating the two, it's having a balance of abilities or success. So I think it's miraculous that we as surgeons can move our hands in a way that we're able to match the visualization of modern microscopes. If you think about it, when you do a capsulorhexis doing cataract surgery, you do an internal limited membrane peel, we're working at a small few microns of thickness of tissues. It's amazing that our hands are able to do this, but ultimately we are. So miraculous or not, this is a skill that a good surgeon can do currently. So in other words, we can operate on whatever we can see so far. Which leads to another question, which is, what about surgical robots? By the way, we've discussed robots for a long time in the world of ophthalmology, and there's situations that robots are required. So if you're doing cavity surgery, usually in the thoracic abdominal cavity with very long instruments. See, the length of the instruments is very important because it magnifies the movement of your hand. So if you do a 1 degree move, turns into centimeters at the tip of a long instrument. So for those situations, I think robots are required to diminish the movement of what we have in our hands, or for inaccessible areas, like I said, when you're doing laparoscopic surgery. But interestingly enough, current ophthalmic surgeries, most of us perform without the need of any surgical robots. Maybe in the future, if we move to a different, smaller magnitude of what we have, but currently I don't think they're necessary. But what are the current improvements in surgical visualization? So as I said, we have this balance. So we talk hand-eye coordination, now we're talking hand-eye capacity, and we're pushing the envelope. So when you think about microsurgical visualization, there's a few things, you can always go back and think about our ancestors that did surgery without any magnification. Then they started surgery with loops. And you think, oh, that's amazing. But you think about the type of surgeries that they were doing when you do intracapsular cataract surgery, you didn't really need much, microscopy. Small loops could be sufficient. The sutures that they were using were fairly large. The instruments were large. But now we move to the microscopes that we have, and think about the microscopes that we currently have been about almost equivalent since the 1980s or 1990s. The bigger things that have happened that I thought about when I was writing these slides, one is the improvement of the red reflex. The most recent one is on the Loxo microscopes, but red reflex visualization was improved a few decades ago by putting some form of angling to a double illumination system so you can do cataract surgery. Then we have indirect lens systems, or multiple lenses, or a system of lenses for wide angle visualization of the peripheral retina. And everybody thinks about the biome. Zeiss has the ReSight. I work with a company, Surge Instruments, that produces the Halo. But they're different concepts. And you can have contact lenses as well, like the ones that Bolt produces, that somebody puts on the surface of the cornea to perform the surgery. And then lately, we've had different dyes, we call them vital dyes, for visualization of transparent tissues. In the world of ophthalmology, in retina particularly, we're talking mostly about the internal limiting membrane and the vitreous. Of course, cataract surgeons think about staining the anterior lens capsule to perform capsulorhexis on a white cataract, for example. And the most common ones are andocyanide green. There's brilliant blue. There's also trypan blue for the anterior lens capsule. There's other dyes, but all have the similar concept of trying to stain a tissue so that you can see it. Or if you think about it more specifically, it's not so you can see it, but you can see a contrast with surrounding tissues. And I think that's important. So these are the most significant visualization improvements. But what about the future? Where are we going with this? Sorry, even while recording, I need to have some coffee. Optical microscopy has reached a visualization limit that is imposed upon it by the physics of optics. I have here a standard, microscope, a laboratory microscope, for example. And we all know that there's a point on a microscope that you cannot get any smaller than what we're doing. And you have to move to different other visualization techniques, electron microscopy, or different other transmission electron microscopy. But for optical perspectives, the type of microscopes that we have, given the eye, may have reached its physical limits. I don't think we can magnify much more than we currently do. So we enter now the digital microscopy revolution. And I don't think it's now, it started a few years ago. Perhaps everybody is aware, or many people have used the Ingenuity system by Alcon. I worked with the predecessor to the Ingenuity system, which is the TrueVision system. It's actually Ingenuity comes from TrueVision. It was licensed to Alcon, which is a great system. So what is the basic concept of any digital microscopy visualization? One is that you have parallel high resolution video cameras. And that allows us you need parallel cameras with different angles so that you can have stereopsis. And then a digital video representation to replace the optical oculars. So there's two ways to do this. Ingenuity, for example, uses a stereo video monitor with wearable glasses to separate the right and left eyes to allow that ability to have stereopsis. Now, these video monitors have to, the way that it is, have to simultaneously present two images in a single screen, because it's the only way to do that. And then you need to have a separate pair of glasses that allows you to separate the images. And these glasses are polarized. That's the most common one that we have. So you have one image polarized in the vertical, the other image is polarized in the horizontal. And by doing that, you're able to have the right eye see one image and the left eye see the other image. There have been other attempts. There's interlaced flicker, basically that there's shutters that move in and out in every eye. And you always see the cheap red-green filters that when you go to a movie back in the days to see 3D videos. Now, I've been working with this company called Bionics that works with a headset with separate image to each eye, and I'm very intrigued about the system, and I'll be talking a little bit more about it as we go into this. What is the current problem that we have with digital microscopy? I think the biggest one is the concept of brightness dynamic range. So the dynamic range is the distance between the lowest, darkest that one can see to the brightest that one can see. So that's the dynamic range. And the human eye it's impressive when you have the combination of rods and cones and image processing. We're able to see a very, very large dynamic range, and we don't even notice it. And current generation of video cameras are simply not as good as a human eye. And so therefore they have problems called blooming, that when it's too much light, the whole image turns bright, white, or the opposite, when there's too little light, the whole image goes dark. This happens less when you're doing cataract surgery or anterior segment surgery, because the illumination of cataract surgery tends to be relatively stable, or a smaller dynamic range. So you're able to accommodate for that. But when you do retina surgery, particularly with the intraocular light pipe, now we have, again, a massive dynamic range in retina. You have to remember that the physics of this is that the light, the irradiance or luminance of the retina is proportional to the second power of the distance of the endoluminary probe to the retina. In other words, so if this is the retina, and this is my probe, as I go closer or go further away, the illumination changes. The further away we go, the illumination decreases, but this is a proportional to the second power. So if I go from, say, 5 millimeters to 10 millimeters, you don't decrease in half, you decrease in 4 times, because of it's the second power to 2. So if you go from 2 millimeters to 8 millimeters, so that would be a 4x difference in distance, you have a 16x difference in illumination, and so on and so forth. So that increases this huge dynamic range, and that's one of the biggest problems that we have. Now, I think it's predictable this will improve as we move on forward, just because cameras are just going to get better constantly. But here's a big and important question. Can we achieve increased surgical efficiency? I don't think so. Maybe a little bit, but not in huge capacity. So I don't think that video microscopy is going to increase surgical efficiency. That's not my opinion. I think when you think about the bigger limit to surgery efficiency in the operating room, it's not the microscope. The biggest issues in surgical efficiency is first of all the surgeon, and second of all the team around the surgeon and the turnover and all these other issues. So they're actually more human issues than technical issues. You know, if the microscope can improve efficiency, we're talking just a little bit. What about safety? What about are these video microscopes able to provide higher safety? Maybe. Now, I think there's a novel concept that most of these companies are exploring, which is the real-time imaging, image processing, so that you're able to see different tissues or highlight of different tissues, so that you can detect edges, enhance stereopsis, decrease the need for dyes. The edges is very important because, for example, one of the difficulties in retina surgery is to see inadvertent peripheral retinal tears. So anything that was able to magnify or demonstrate that better is important. Now, I'm a cynic when it comes to insurance companies. I think that they're the largest evil in the world, tongue in cheek, but maybe a little truth to that. Insurance companies will simply not pay for higher safety unless they can see a benefit to their bottom line. And this is a very high threshold to prove. I was just at a lunch before coming here, and somebody was saying, well, will insurance companies notice that when you put a better intraocular lens, the patient is less able to fall? Like, those data are very difficult to prove. And at the end of the day, costs are very important for them. And so I don't think that safety is going to be an issue. It's going to make us get more money, particularly to have these expensive transitions. I think this is important, and I think this is a point that is not properly discussed, which is the access to data. Currently, I believe that the preoperative space, the intraoperative space, and then the postoperative space are too disconnected. And I find that companies that work for ophthalmology particularly, they're trying to do this concept of the incorporated intraoperative incorporated room. And I think cataract surgery is one place that this is moving quite a bit forward, because you have companies that are trying to own intraocular lens biometer calculators with microscopes with different concepts to put them all together. I think that's interesting, but I still think that we have a lot of data that's not transferring in a very good position. And even when we transfer from the preoperative to the intraoperative, there's very little transfer from the intraoperative to the postoperative. In the United States, we still have to dictate a paper surgical report. I think that this is very interesting. This paper surgical report is usually a description of the surgery. I think that happens in most countries where I've talked to people, but I find it interesting that we're generating troves of video data, but we still depend on this sort of 1940s technology. So maybe the future, the surgical video will be a medical record, not something that we dictate, Another part that I intentionally didn't mention is intraoperative optical coherence tomography. It's intraoperative OCT. Because it's not necessarily the same thing as digital microscopy, but intraoperative OCT or any other intraoperative technologies, the problem that they have is how to present that information into a coherent image that the surgeon can do. But I'm going to go back to this concept. Why do I support the transition to digital microscopy? One is because I think we've reached a plateau in ophthalmic surgery. I think that when you go to conferences, you basically are hearing very similar concepts now. I think particularly cataract and retina surgery, of course, there's some movement forward. You see different lenses, you see different smaller techniques, et cetera. But when you think about the actual capacity of our ophthalmic surgery, we tend to be in a mature field. A mature field is one that we have now smaller gains every time. The big leaps have been created. At some point, vitreous surgery was considered something exceedingly dangerous, and now it's a day-to-day operation. So it's changed. And I already mentioned this, we can already perform difficult procedures with optical microscopy. So why would I pursue the transition? We have reached near optimal efficiency with our current systems. As I mentioned earlier, I think that the majority of the problems that we have in inefficiency in surgery are not related to to technology for the most part. I already mentioned my point that payers, those that pay for the surgeries, are rarely willing to pay more for current surgical procedures. There's exceptions, and the biggest exception in our field is, for example, premium intraocular lenses. But the problem is that we cannot achieve higher efficiency or much lower costs. We can improve some things, but no. So why do I support this transition? And this is what I think that we need to go is, what is the future of retinal surgery? And I think that's the question that we need to ask ourselves. And the future of retina surgery, ophthalmology in general, and retina in particular, will involve incorporation of gene therapy, tissue and cell therapy, tissue transplantations, in a way that hasn't been done to this point. We've already started seeing this process with subretinal injections. I worked with a gene therapy company performing subretinal injections for gene therapy. And even though we can do gene therapy, subretinal injections gene therapy, there's a lot of questions about dosimetry and the size of the bleb that digital microscopy can help us. I think that optical microscopy is limited for this transition that I predict will be happening in the next few years. I think that eventually we will need tangential visualization. Basically, we currently are seeing down into the eye, but sometimes we're going to need to see at different angles with the endoscopes. And even though the endoscopes have been existing for a long time, we haven't learned how to use them properly. And I think that the transition to digital microscopy will help us. So in a way, we will need to find a way to see things that we currently not see, which is how to differentiate tissue grafts and cells and how to enter the subretinal space. So now the transition, the company that I've been working with is called Bionics. It's actually an Israeli company. I know that there's a lot of animosity between the Arab world and the Israeli world, so this is not a political statement. But they work this helmet that we have is the F-35 helmet, and I just want to think about what the future can potentially be. So
pilots who fly the F-35 fighter jet wear a helmet that can see through the plane on all sides.
This is a helmet.
It's worth $400,000.
Notice how the data and information has been presented. So these are things to attack. Sorry, I just pressed something there.
Each helmet is fitted with noise-cancelling headphones, night vision, a forehead-mounted computer, and a TV screen-like projector that displays live video on its clear visor. But what really makes this helmet so special, when it's combined with the sensors and exterior cameras mounted to the F-35 fighter jet, it gives the pilot the equivalent of X-ray vision. So when the pilot looks down, they can see straight through their own body and the floor of the plane to the terrain below. The helmet also supplies such information as target identity and distance, and even advises which weapon to use. So when looking through the plane, if the pilot sees something that should be hit by a missile or just wants to get a closer look, all he has to do is look at it to lock on, then flip a switch to zoom in or fire away. Because the helmet is custom made and costs $400,000.
So the point I'm trying to make here with this is when you think about the military industry, the physics of flying a plane hasn't changed since the Wright brothers. Technology has improved. But when you think about F-15 fighter jets, if anybody has seen that recent movie with Tom Cruise, Maverick, and he goes back to flying an F-14 after flying these fancy new systems. The interesting thing is that they make this point of how this transition of technology has happened. But what about surgery? So this company that I've been working with, and I'm going to move this presentation to its end. Thank you. I'm going to move to the next slide. I hope you can still let me. I think I need to stop sharing and change it, or maybe I'll go to this one. Let me stop the share and start the share again from a different screen. So I'm starting in here. So I want to talk about my experience with the Bionic system. It's an exoscope, the term exoscope to separate it from a microscope, which is an augmented reality system for microsurgery. By the way, so this company is an offshoot of the Israeli company that creates that headset for the F-35 jet. So if you think about what we just saw in that small video, you saw a pilot flying. He had whatever he saw, he could see through tissues, through the tissues of the plane. The helmet immediately marked information that he could have to process really fast. Well, in our situation, there's things that we want to know. We want to know where the retinal tear is, where the edge of the capsular rhexis is. We want to know the depth. We want to know what's happening in this location. When you think about intraoperative OCT, how do you present that information built into a system? When you have vitreous hemorrhage, can you see through the blood to know where the retina is, which we currently don't know? So the Bionics one is a high-definition, fully digital imaging platform, enables surgeons to see a magnified 3D view of the surgical field. So this is the helmet, and this is the microscope. This is a microscope that has zero optical perspectives. It's all pure digital. It is untethered visualization, and I came up with the term of tethering. I think that I'll explain in a second, but when you are talking about optical microscopy, you are you're tied to the position of the oculars. When you think about general video microscopy, when you have a big screen, now you're tethered in two ways. You're tethered in an angle. You have to be looking at that screen. You cannot look away because that's where the surgery is. In retina surgery, we end up having to put the screen at an angle, which has a change in the angle that's on the Ingenuity system. Another tethering that you have is the angle of your head. If you're using a screen, the stereo vision view requires the right and left image to be in this position, not in this angle. So if the surgeon changes the head angle, they'll lose the three-dimensionality. So this is the concept of having this ergonomic thing. Now, what is interesting is that they're able to put gyroscopes on the headset. So if you think about using the Oculus virtual reality headset for gaming, you put the headset, when you move your head, the gyroscopes measure that head movement. So with this system, you're able to move your head and use it to control the microscope. You have a foot pedal similar to the foot pedal that you have on a regular microscope, but that foot pedal, basically the main function of it is to click a button while you move your head to tell the microscope what you're doing, so that you can now focus with this movement. You can pan across different images by just moving your head. And you can zoom in and zoom out also with small movements of your head, which I think it's a very interesting concept. And now we're moving into image alteration or image processing based on head gestures. So there's a motorized arm. This is a stereoscopic camera head unit. The user interface, which is touch screen with a beautiful screen, that's one of the biggest issue. I'm going to show you a surgery that I performed a few months ago. I've done quite a number of surgeries. I was told recently that I may be the one that's done the most of these, vitreoretinal surgery with this microscope in the world. I'm kind of proud of that. I know it's not going to stay for long, so I'm happy to say that. But now I'm going to show you something here. These are OCTs. These are not intraoperative. These are preoperative OCTs that are placed of a patient with a dense epiretinal membrane. These images are not altered or edited, so you can see the quality of the device. This is a membrane peel, and if you have more time, I can show more different surgeries. This is with the Bausch & Lomb Elite system, and I want you to see the clarity of the system. When you're looking at this surgery and you look at information above here, what you'll be seeing, so it's a little air bubble, is the head gestures as I'm moving my head and changing settings. So this is a focus. You see the movement up and down. You can also see the panning. So this is focus, and you can control this. And you get used to really quickly seeing through these things. That's an epiretinal membrane. That's the real-time view of me peeling a very dense epiretinal membrane. So you're panning. We can change different filters, as you see here, as the membrane gets peeled. A little blooming happened. You learn to pull your light pipe away a little bit. I was kind of proud of that epiretinal membrane peel. After that, we did an ILM peel that I think will be wonderful to see. I believe that this is part of the ergonomics of surgeons. Surgeons, particularly ophthalmic surgeons, have a whole bunch of problems with musculoskeletal pain, particularly in the neck and in the back. And as you see when I'm doing the surgery, I have no oculars. I can put my head or my back in every position. I can lean back and lean in any direction. This microscope has a cable that connects to it. The next generation will not have a cable, so you wouldn't even have that. And as you can see, you have the indirect ophthalmic system connected to the bottom of the microscope. This is an image of the operating room. And you can see it's my operating room is fairly small, and we had no trouble. But I think this is the part that's interesting. So I'm connected. This is an Apple camera looking at me, and I'm wearing a microphone. So this is demonstrating an intraoperative. So I'm doing a very difficult fracture retinal detachment. And here on the screen is a friend and colleague from Boston. So I'm having an intraoperative conversation with a surgeon that she's seen a three-dimensional view hundreds of miles away, thousands of kilometers away from where I was. So you can see the head gestures as I'm moving my head and achieving to, you know, the different things that we need to do.
What's your favorite color for painting or any?
So this is my friend from Boston, Caroline. So the point here is that you can have these different conversations at real-time surgery. And I was trying to show how the head gestures of the microscope are controlled and how you're untethered. Let me move on forward here. So the concept, of course, this is a marketing slide for Bionics, and I just believe in the product. I think it's an enhanced system, but I think the bigger issue to me, I'm gonna stop on that. I'm gonna continue this part over here. I think the biggest important thing for me is where can we go in the future with this, and what are the things that we will be able to do in the future with digital microscopy for surgery. I'm willing to take any questions. I think this is an interesting concept, and I'm happy to chat with most of you guys. Thank you very much. Merci beaucoup. Hey everybody, I happened to join in at just the right time, so I appreciate the the coordination.
Hello back. It was a great presentation from you, Dr. Jorge. So we move into discussion.
Jorge, what about the weight of the helmet? You know,
that's been made as a question, but I strongly believe that, listen, Carlos, there will be fighting amongst companies that want to enter this space. And every company is going to try to argue against the other. And I have a consultant in this company, I admit it, but that doesn't mean that I think that other great devices are not in different companies. But certain companies have made the point that it's too heavy. It's not. So I've done in a single day 12 cases, and I haven't had any trouble with it. Okay. The only problem I had was sometimes the cable would get stuck into something behind me and somebody had to unstuck it. And that's going to change once they make it wireless. The other part that was the logistics of how to put this on your hand. So what I would do is I would use double gloves. So I would start the surgery, put one set of gloves and then another set of gloves so I can put it and feel comfortable, then remove the outer glove and move on forward. Now, the cataract surgeons have a different sense of efficiency than we do. So the cataract surgeons, they have surgeries that take about like 27 seconds, you know, really fast surgery. And on the other hand, it's the change between case to case that's more significant. In our cases, you know, our surgeries are longer, so a few minutes of changing doesn't really make any difference. So, for example, the device has something called a see-through view. You turn it on, and now you can see where you are in the operating room. I don't really use it that much because when I put it, I'm sitting down. Now, the cataract surgeon may want to keep it on to go to the operating room next door and proceed to the next surgery. You see? And in that situation, he will want to put the see-through so that he doesn't hit the wall, you know? But I think those things will get improved as things get better. I think the interesting thing, truthfully, you know, every company is moving in this direction. And I think intentionally I left the question of intraoperative OCT out of the discussion, okay? But now I do want to address it. First of all, I'm curious about your perspective in intraoperative OCT. I'm sure that you've tried it. My first belief is that if you need an intraoperative OCT to see an epiretinal membrane, you shouldn't be doing surgery in the first place. So that's one part of it. On a different part of it, there are things that we are moving forward. For example, I've been an investigator for Regenexbio. And in Regenexbio, we do a subretinal injection of a very specific 150 microliter for the transfection of this virus. When you end up realizing is, okay, we all do subretinal injections when you do a subretinal hemorrhage or something like that. But the question is not, can you do an injection? The question is, can you deliver exactly 150 microliters of device? So this is where I think that intraoperative OCT will come in to be able to do volumetric measurements of something like this in real time. But from the perspective of the digital visualization, and Alcon with their great system, with their ingenuity is working on this. The question is not, how do you put this data here? The question is, how do you integrate it into the seamless view of your surgery? Just like that pilot can see this plane here is the enemy, and he's flying at this speed and at this altitude. Well, we want to know, what is this? Should I do this? What's the depth? Should I not touch it? Imagine, for example, this is me thinking ahead. Right now, we're limited by the visual, the wavelengths of visible light that we can see. But imagine doing an infrared illumination with infrared cameras that allows you to see through a vitreous hemorrhage. And now you could potentially be, how many times have you done a vitreous hemorrhage on a diabetic that you know the retina is somewhere there, but you don't know where it is? You know, and we have our ways to kind of go slowly and carefully to find it, but it would be wonderful if we actually saw where the retina was. So I think what I'm trying to say is that there's going to be a shift, a transition in the how you see things and the information that's built into the image, not parallel to the image. Mm-hmm. You know, now that's intellectual property and everything, but I think that's the interesting part of where we're going forward.
Great talk. Great.
Thank you so much for this interesting and futurist presentation. We have a lot of questions from the audience. We can't take all of them. Maybe I'll ask you a few questions, maybe two. The first one, is there a latency period between the visualization and the surgical procedure?
No, there's no latency, no noticeable latency. Latency was a problem in the early versions of the Ingenuity, and they've gotten better. In this system, there is no noticeable latency.
All right. The second question, do you believe that young ophthalmology trainees should learn on these new platforms straight away, or do you think that there will be always the need to the old way first?
I think this is a different question. The question is not, should ophthalmologists learn this technique? I think you're addressing a point of, let me ask a different question. I bet you that the average young ophthalmologist grew up doing video games, and many of them have already played games with augmented reality with the Oculus. So the question is not, do you have to train? I predict that you are already pre-trained to do this. You know, I happen to be this weird age where perhaps my age is, I'm the youngest, well, I don't know what to say. Like, I still remember the first iPhone, but I was playing video games when I was 7 years old. So in my age, people older than me probably didn't play video games. People younger than me have had video games all their lives, and much younger than me have had iPhones all their lives.
You're like hybrid.
Exactly. So this is just because this is kind of like middle age. Anyway, but the point of the matter is that I actually think that the young ophthalmologists are going to have almost zero learning curve in these new technologies because they've grown up with this. This is what they do. They leave the operating room currently and go play video games. Am I correct in this, or am I exaggerating? So I don't think it'd be
exactly. Yeah.
Not me.
From this,
Continue working. Yeah.
So I don't think you need to train. I think it'll be natural.
Great. Okay. Thank
I would
you.
have a question. Does the device have special filters like on the Alcon Ingenuity or not? like to
Yes, it
enhance
has.
the visualization of the ILM and all that stuff?
Yes, yes, and I've been working with them on improving those things. I think one of the interesting things, and I actually notice it more. So we have different filters and color filters and what have you, and certainly it makes it when you stain the ILM to have a very high contrast of what you're seeing. But I noticed we were talking about silicone oil earlier, and I was doing a case of removal of silicone oil, and I was really bothered that I was seeing all these lines in front of the cornea, only to realize that the device was highlighting the edges of the silicone oil bubbles. And so edge highlighting to me is more important than color highlighting, because it allows us to see things that are subtle. And for me, the most important thing is retinal tears. You know, a peripheral retinal tear visualization, that is a big thing. Now, hopefully in the future, it'll tell us, look, there's a tear there, okay? It'll mark it, you know, kind of like this is your enemy, you know? but at least highlighting the edge is already a move in the right direction.
Great.
So the future is here.
Exactly. Thank you so much for this great presentation. And we'll pass to the last one about endophthalmitis. That it's the most dreaded complication, the fear of every ophthalmologist. What is the place of vitrectomy in the management of this nightmare? To answer this question, we are the pleasure to have with us Dr. Sallam Ahmed with his talk about endophthalmitis and vitrectomy. Dr. Sallam is professor at Harvey Jones Eye Institute at University of Arkansas for Medical Sciences. He is a retina specialist with extensive expertise in both surgical and medical arenas. He has a particular interest in ocular inflammation and infections, and actually he is the ophthalmology residency program director for University of Arkansas. We are absolutely thrilled to learn from his talk today. So, dear doctor, it's for you.
Thank you so much, Sarah, and thank you so much, Yassine, for the kind invitation. I'm actually the one learning, and again, I regret missing all my French lessons when I was a kid, but I could understand some bits and pieces. So I'll talk about endophthalmitis surgery, as asked, and I thought of just putting together a few bits and pieces here just before going into surgery. So what's happening for post-procedural endophthalmitis? What's the current evidence pushing us, and what do I do? So I usually do a TAP, a vitreous TAP plus intravitreal antibiotics, and my aim is to do this within an hour and hopefully half an hour of presentation. PPV, we can discuss that later if the eye did not settle down, but my first to-go treatment is intravitreal antibiotics. And then we know that there's no benefit of antibiotics as seen in the endophthalmitis vitrectomy study. That's what it told us, although maybe quinolone reaches inside the eye, systemic quinolones. So the argument is that the endophthalmitis vitrectomy study is not recent, maybe that not the best instrument. So what's the current evidence for treatment of post-procedure endophthalmitis? So we looked into that in one study from Europe, and we found that actually most surgeons do not follow the endophthalmitis vitrectomy study, meaning that 75% of the surgeons, regardless of the vision, they do vitrectomy. Because I think the belief is that the instruments are safer, we're better surgeons, and also if there's an infection, you need to go and clear it out. Then in the report 2, we looked at, okay, what are the results? And interestingly, the results was actually that intravitreal antibiotics was not inferior at all to parsplana vitrectomy. So doing parsplana vitrectomy did not do the patient any favor. And that's exactly what the endophthalmitis vitrectomy study told us. And this is really a great study, came in October 2021. That was a meta-analysis of most of the evidence out there, whether on intravitreal antibiotic versus parsplana vitrectomy for endophthalmitis, and it showed exactly what we found and other groups found as well. It's intravitreal antibiotic is not inferior to parsplana vitrectomy. So that's what I do. Let's talk a little bit about endogenous endophthalmitis. Endogenous endophthalmitis is a little bit different. The reason is that, as you can see here from this macro slide, the infection comes from the choroid into the eye. So then there is a role for systemic antimicrobial. And if the lesions are not raised and not inside, did not like breach into the blood retinal barrier, the outer blood retinal barrier, systemic antimicrobial could be more than enough. If not, then you need intravitreal antibiotics in addition to the systemic antimicrobial. And that's so important to note, that the role of antimicrobial here is the systemic one. So what's the role of vitrectomy in endogenous endophthalmitis? It's not clear. So in bacterial, very little evidence. When you look into endogenous bacteria endophthalmitis, very little evidence. And I think the main factor is morbidity does limit early surgery. Most of these patients are sick. Many of them have the other eye involved. They have lots of things going on. So morbidity does limit early surgery. So it really is undetermined what's the role of vitrectomy. But mainly for complications, of course, that's obvious, vitreous opacity or epiretinal membrane. But the main question, does vitrectomy and endogenous bacteria endophthalmitis improve the vision? We don't have the answer for this. Right, okay, what about fungal endophthalmitis? We looked into that. And again, for complication, yes, definitely. But the important question, does it improve the vision apart from the management of complication if we do early vitrectomy for these patients? And we found actually not. It does not improve the vision. And again, a factor here, endogenous fungal endophthalmitis, patients are sick. So really, I wouldn't spend so much time trying to get a vitrectomy done early on. I would get on and treat the eye with systemic and intravitreal antifungals. Let's go to surgery. I'll show you here a few surgeries. So this is here a patient with endophthalmitis. I moved away from peeling off all the membranes because I found in uveitic eyes, including endophthalmitis, that comes back and haunt you. So I try only like here to just open the membrane and trim them. And then rather than strip them off the iris, we do vitrectomy under air to get a good sample. Now, once we did this, we cleaned the anterior segment with the irrigation now inside the eye, and we trimmed the membrane and peeled off the fibrin membrane over the iris. We did not want to do this early on so as not to dilute the vitreous. Now we go for vitrectomy here. And my advisory for people doing vitrectomy for endophthalmitis is to be very conservative, because the retina is very friable. And if you have a tear, most likely the outcome is not be very good. So this is a case we did recently. So just a gentle trim there. Luckily enough, the hyaloid was separated. This is the way we put the antibiotic in at the end. Is the eye we filled with air. And then we use the last stroker. We take the infusion cannula in and put the antibiotics. A question usually asked, do you need to decrease the dose of antibiotics if you have a tamponade in the eye? The short answer, if it's an air-filled or gas-filled, you do not change the concentration. If it's silicone-filled, you half the concentration. We can talk a lot about this, but this is like the short answer for that question. And now we take the trocar out. Okay, here, that's another case here. And again, removing the vitreous. The question is, shall we remove the hyaloid? Again, benefits and risks. And you all understand the benefits is you're releasing, releasing traction and also leaving less areas to cause traction later on. But the risk is that if you have a break, the outcome is not going to be very good. So in this case, we remove the hyaloid cautiously, but I think it's a step I would advise you to think about before doing it. And of course, you open the, you remove the pre-retinal exudates and pre-retinal pus lesions, but the risk is creating a break. Another question, shall we shave the vitreous, like in this case here? And again, my advice now is not to do it. If you end up with a break, it will be a really bad outcome. So I would be cautious doing that. And again, my advice is to just do a limited vitrectomy, remove the central vitreous, and do not end up with a break. Because if you end up with a break, the outcome is usually not very good. In this case here, in all cases, we had an inferior break there. Okay, take us to the next point, gas or oil. So if you do not have any breaks in the retina, I would not use a tamponade. I may use air just to keep the eye formed. If you have a break in the retina, same principles applies like any other type of retinal detachment. If there's no significant traction on the break that you are not able to relieve, I would use gas. Oil, in my view, is really very bad in any case, and is really very bad in endophthalmitis as well. So I think the mix of oil and unrelieved traction is not a very good mix, and usually these eyes do not well. But I mean, it's a situation that you may not be able to avoid. For if you have tears and unrelieved traction and bad view, I mean, you would have to put oil, but these eyes do not do very well. So it comes in, the question is, okay, well, we should use oil because oil is antibacterial. So let me show you this curve here. This is the concentration of an antibiotic versus the time. There's something called the minimal inhibitory concentration, which is what's enough to kill a bacteria or to affect or inhibit a bacteria. If you're in the range between 1 to 4, then this is a bacteriostatic drug. If you're in the range of 10 times, that's like what they call it the Cmax, which is enough for you to significantly kill the bacteria. And that's where most bactericidal medicines are there. So where is silicone oil here? Silicone oil is only a bacteriostatic, so it's playing between 1 and 4 times the MIC. While if you use vancomycin at a dose of 1 milligram, we're talking about 50 to 200 times the MIC. This is called super MIC, which is enough to go into biofilms, and that's the dose of antibiotics you take if you have encephalitis. And that's, again, the argument that you don't need to drain the endophthalmitis. It's not like an abscess you need to drain, because you're using here a super MIC concentrations of the antibiotics. So I don't think using the oil because it's a bacteriostatic is a good thought. I think using the oil, if you have to, then yes, if there's no way to avoid oil, then I think that's justifiable. Let's talk about surgery in fungal endophthalmitis. So I told you about my interpretation of the evidence on what we did, and we found that actually it does not improve the vision. We found, though, that it decreases the risk of retinal detachment later on. I think I would go ahead and treat the patient and think about vitrectomy. This is a patient that was treated with systemic and intravitreal antifungal. This patient who's a drug abuser, intravenous drug abuser, and then the patient was left with vitreous opacities and epiretinal membrane. And the patient got a granuloma lesion on this area here. That's when after it healed. And that's the appearance here after it completely healed, and we went for the surgery. So again, remove the vitreous, we peeled the ERM, and there was residual traction. So we peeled the ILM, which usually is something I try to avoid unless we need to. We can see another fungal lesion there. Then I did not touch that lesion because there's no point in touching that lesion. I mean, it's a lesion away from the macula. It's already integrated in the retina. And if you touch it or try to dissect it, you'll end up with a problem and you'll have to use a tamponade. And so we just left that lesion behind. This is a different patient with, again, a very nice fungal ball, and that lesion is sitting on the optic nerve and the macula. And in this one, that's the one that you want to remove, and you try to dissect out of the eye as we did here. And again, that's a patient who was an intravenous drug abuser, and we treated systemically and intravitreal. Then we used surgery to clear the vitreous opacity and the macular lesion, and then we pulled this out of the eye through the posterior capsulorhexis. I think that takes us really to all what I want to say about endophthalmitis surgery, and I'm happy to entertain any questions you would have. Thank you so much.
Thank you very much, Dr. Sallam, for this great presentation. I'm sure that you saved several eyes doing this great job, even if the visual acuity outcome, it's not, it's like the same. But
I feel I saved many eyes not doing that surgery. I think really, and again, that's my thinking always in intravitreal, in endophthalmitis. I think you do better not operating on these eyes and give them intravitreal antibiotics within an hour, if not within half an hour of presentation.
Mm-hmm. Okay.
Ahmed, let me ask you one thing about
Yes.
so much of this, severe endophthalmitis, have hypotony. And then is your indication to use silicone oil, or what would be the indication for you to use silicone oil?
For after
Here.
vitrectomy. After vitrectomy.
Yeah.
So like later after vitrectomy. So the indication of vitrectomy was to clear the infection or to deal with problems later on. You're saying.
I mean, imagine that severe endophthalmitis, as you showed, with the posterior hyaloid white, and you remove it, and you try to clean the periphery, and we know this is so difficult. But the patient was 3 millimeters of mercury, was hypotenuse, the cornea is edematous. Is your indication for silicone oil or
no?
not?
I would not put oil because I think, again, I think oil in hypotenuse eye, in my view, is not a good idea because the oil will end up in the antechamber. One of the reasons the oil stays at the back, even in phakic eyes, is because there's aqueous. And I think the oil will come to the front and will be the problem of the hypotony and the oil. So in this eye, I'll do my best to just remove as I can do safely. If I can clear over the ciliary body without going over the retina, I will do that, and I will just close the eye.
And what about the lens?
The lens, the IOL?
No. The crystalline lens.
Well, if it's, I would leave it unless I cannot see. And even if it's an IOL, like after cataract surgery, endophthalmitis, I would leave it because the intravitreal antibiotics at such a high concentration, it penetrates into the biofilms around the lens. But if I cannot see it, if I cannot see well, I'll remove the lens and I'll remove all the capsule. I'll remove, like, if it's an endogenous endophthalmitis, let's say, and I cannot see well, I will remove the lens with the capsule, with everything out.
Great.
Have a question. Is there any place for endoscopic vitrectomy when the medias are not so clear? So you should use the endoscopy.
Endoscopy, yes. I mean, yes, I think endoscopy is a very good view, but in most cases of endophthalmitis, I think you can see very well once you clear the antechamber and once you start clearing the vitreous. I think the endoscopy is a good idea and we use it, but it doesn't give you that good view. The other thing, which if the cornea is so bad, we use temporary keratoprothesis. You get much better view than the endoscope. But I think endoscopy is fine as well.
No.
And when the view is not good in endophthalmitis, like the anterior, there's a problem with the anterior segment view, just try to find out, is it the problem in the antechamber or it's in the cornea? If it's an antechamber, 100%, you can clear that once you're in the eye.
And do you use a keratoprosthesis like when the cornea is very bad and is opaque?
Yes, if the cornea is like really, really opaque, I would have the option of keratoprothesis. Interestingly, with the wide field view, you can really have a very nice view through an opaque cornea if part of it is clear. But have that option if the cornea is really like gone. And usually these cases are post-corneal ulcer endophthalmitis with perforation.
Yeah, bad outcome. And as we've seen, you're a little bit minimalist. Like you try to remove the less of vitreous, but don't you think that when we have a vitreous, remnants of vitreous, it is a base of reproliferation and base for bacteria's infection, chronic bacterial infection?
Yassine, I think this is a great question, and I try to do the minimal I can in any retina surgery. My view is this. Let's talk about diabetes. If you think about diabetic vitrectomy, your question to Dr. Mohammed was fantastic. You remove everything. Yes, if you remove everything, you'll avoid traction. You will avoid rebleed. But if you create a break and you don't clean around it because it's all stuck down, then your chance of losing the eye is very high. And I think that applies here. Yes, if you remove everything, it's fantastic. But if you have a problem, a break, you lose the eye. So I think it's a balance. And the more you become experienced, the more you really like have a better gauge of gauging things. so I try to do the minimum and not run into problems. And I think less is more for everything in retina.
This is best.
I think less is more.
Thank you for this amazing presentation and talk. So on behalf of the Young Committee, I would like to thank all the speakers for the great presentation. It was a tremendous afternoon during summer vacations. We learned a lot. We discussed such controversial topics with such great surgeons all around the world and local surgeons. So thank you for being with us today. This was our first webinar in the retinal series, and we hope to see you in face-to-face meeting very soon in Morocco here. So you will be always welcome. Thank you for being with us today.
Thank you.
Thank you so much. Thank you.
Thank you again. Thank you. Thank you for these great presentations. Thank you for being with us. And I hope it will be a serial of Retina Summer Camp or winter camp, whatever. And we really hope to see you soon, maybe face-to-face in Morocco or somewhere else. And on behalf of you, Young board, we really thank you for your presentations and hope to see you soon. Thank you.
Thank you, everyone.
Thank you.
Bye.
Bye-bye. Thank you.
It was great having you. Bye-bye.
Bye.